Good afternoon, everybody. On behalf of the AMOX Endocrinology Committee, this is Dr. Pratik Tambe, welcoming you all, our distinguished faculty, as well as the audience who have tuned in for today's program. The theme for this program is high risk pregnancy, and this program is in association with the Foxy Food, Drug, and Medico Surgical Equipment Committee, the chairperson for which is Dr. Vidya Thobi. We also have a host of societies from Karnataka who have joined in with us today in this program, and their office bearers are here. We are delighted to have all of you amongst us. And these societies are the Belgaum, Bijapur, Hubli, Manipal, and the Tumkur societies. We have a great academic feast in store for all of our viewers. And without further ado, I would like to proceed with the introduction of the first set of chairpersons. Can we go? Yes, there are some few do's and don'ts, and these are from our backend team, Science Integra, who has been the academic backbone for so many webinars and academic events which are happening throughout the country. Today's program is in association with Bharat Serums and Vaccines, who, through the Bridging Bharat initiative, have conducted more than 100 events in the past 3 to 4 months since the beginning of the lockdown. So we are just going to start with a few simple do's and don'ts, and these are for the faculty. These are well known, but just like to remind everybody, no offense meant and nothing personal intended when I say this. Please mute whenever you're not speaking. Please don't hold the mobile phone to log in because then you will end up with selfie hand, which is not a very good thing to have after 2 hours of holding the phone up. Next slide, please. Of course, we must ensure that we are appropriately dressed at all times. Next, please. And as far as possible, if you are attending to a phone call or you are attending to emails or multitasking in any way, then please mute and switch off your video as far as possible because it becomes distracting for the audience as well. Next slide, please. This is not required. I'd like to introduce and formally thank our office bearers of AMOGs who are going to be there always for us. And every time I want to do a program, the simple one liner from them, both my president, Dr. Nandita Palchetkar, and the secretary, Dr. Arun Nayak, is please go ahead and spread the lamp of knowledge, the light of knowledge as far as possible. Make the most possible of this lockdown that we have. Reach out to as many people as possible and try and include as many distinguished faculty from teaching profession as possible so that we can spread knowledge wherever we go. Next slide, please. Thank you too much so much for our to our office bearers of AMOGs. We also have Dr. Kiran Kortakoti, who will be joining us a little later, and Dr. Rohan Palchetkar. Yes, Dr. Kiran Kortakoti is here. I think his surgery is over. Thank you so much for logging in, sir. We'll be formally introducing you in just a minute. Also, let me take this opportunity to thank Dr. Vidya Thobi, Professor and Head of Department of Al Amin Medical College in Vijayapur, Chairperson for the Foxy Food, Drug and Medico-Surgical Equipment Committee. She is the organizing chairperson for Kasoga in the past. She is the treasurer of Kasoga at present. And we thank her for wanting to associate with AMOGs. And we've had a long association over the past 3 4 years. And I think in the webinar times, the pandemic times, this association has only grown even stronger. Next slide, please. For the formal introduction of our chairpersons, I would like to hand over to Dr. Vidya Thobi, who will conduct the further proceedings. Welcome, ma'am.
Thank you, Dr. Pratik, and it is indeed pleasure always to be associated with AMOX. And I have done many programs with AMOX, and I'm very glad that today's program on high-risk pregnancy and everything is happening because of this great association. Maharashtra and Karnataka always work together, and it is like my mother's place and India's place. So always I would be glad to be associated with AMOX, and I'm very pleased with the galaxy of the speakers and chairpersons and various societies of Karnataka who have joined in. So I welcome Dr. Ameya Purandare, who is also a past chairperson, and with always with his guidance, I work in for my committee and other speakers as well. I'll not take much time, and I want to welcome now and wish to. I'm very happy to introduce Dr. Kiran Kurtakoti for this August gathering, and he has many things to say about. And in Foxy also, he was very successful chairperson of MTP committee. I have witnessed in the past, and also he is at present second vice president of AMOX, chairperson of medical education research and training AMOX, and second joint secretary AMOX. So in AMOX also he has worked very hard, and he has done many conferences, and very many of them I have attended personally. He is very successful organizer of these conferences, and he has many publications as well. We all know his very good book on MTP, and he did various MTP workshops as well. And I would like to say that I'm very closely associated with Dr. Kiran Kurtakoti many times in Pune. So over to Dr. Kiran Kurtakoti. Okay, Dr. Pratik will
Yeah.
introduce the next chairpersons. Yeah,
Next slide, please.
sorry.
We have amongst us Dr. Tilotama Naidu, who is the president of the Bijapur Society, and she is somebody who's been a great asset not only to the Bijapur Society but also to Kasuga. Madam is a very reclusive person but a very highly sought after teacher, and I think she will be joining us any moment now.
Yeah,
When
yeah,
we
sure.
have her, we can have a few words of wisdom from her. I think you're the right person, Dr. Vidya Thobi, to introduce this
I have
great
introduced
legendary
Dr.
figure.
Murlidhar Pai n number of times. And for the Kasoga family, Amox family at the national level, there is no introduction for Murlidhar Pai. He is most sought after speaker, and I would like to read all of his CV this time, because every time I do know, I will just tell that he is very well known. He's a best outgoing MD candidate, topper in DGO, 8 times best teacher, 3 times best teaching material awards at KMC Manipal, author of Holland and Bruce Manual of Obstetrics, and he was a corresponding national editor. He got the best jury for the best article award for our Jogi, national chairperson of Public Foxy Public Awareness Committee 2004. He has got many awards, fellowships, more than 100 publications, more than 500 presentations. And I think I was last time only I was telling that he will create a Guinness Book of Records for the webinar presentations. And he is very good teacher, academician par excellence, and more than 34 years of teaching experience as well. So welcome Dr. Murlidhar Pai for this exclusive webinar of Kasoga and Amogs. Yes.
Next slide, please.
Yes.
We have with us Dr. Satish Dhamandkar, who is the president of the Belgaum Society. He's an associate professor and consultant at the KLE Centenary Charitable Hospital in Belgaum. Has 28 years of private OBGYN practice, has been the IMA president in the past, and of course, he's been awarded several prizes and awards for all his role, contribution to academics, and of course to medical practice as well. Welcome, Dr. Satish Dhamandkar. Next slide, please. Dr. Vidyathobi.
Yeah, yeah. I think Dr. Basavaraj Sajjan has joined or not. I don't know. I'm not seeing him in screen. But he's a senior consultant in OBGYN. Mainly his work is on HIV. The medical director of City Hospital Koppal, and he's a South Zone coordinator for our HIV committee. And he's a senior OBGYN specialist, and also he works as a Koppal Institute of Medical Science, Koppal. So welcome Dr. Basavaraj Sajjan for this August gathering.
So before I hand over the scientific proceedings to the chairpersons, there's just one small announcement to be made. Unfortunately, Dr. Suchitra Pandit, our past president Foxy, who is supposed to be the first speaker, she is unwell and she is not able to join us. So we will have my good friend Dr. Ame Purandare, the state coordinator of AMOGS, to speak first on his topic of cervical cerclage in the 21st century. And after him, we will have Dr. Rohan Palchetkar, who was originally supposed to be one of the chairpersons, but he has kindly consented to deliver a talk on pregnancy after 40 slash impaired ovarian reserve. So that's just a slight change in the sequence of events. And for Dr. Ame Purandare's formal introduction, I would like to hand over to none other than Dr. Murlidhar Pai. I think two titans of academics, one from Kasoga and one from EMOGS. They are actually a made for each other couple. Thank you so
Yes.
much. And we hand over to the chairpersons for the further proceedings. Can we have the slide up, please?
Okay. Thank you, Dr. Pratik. It's always a pleasure to be among the youngsters, especially dynamic youngsters like Pratik Tambe and Rohan Palshetkar and the speaker whom I'm going to introduce. What shall I say? I'm actually feeling that it's a pleasure and a privilege to introduce this dynamic young speaker, Ameya Purandare. He is not only dynamic, he is dashing. His energy is something infectious. In fact,
Yes.
all of yours.
Yes.
And their efficiency is admirable, and their calmness, the calmness with which they work. I have seen the whole of last year, these three were the actual tripod of Foxy.
Yes.
Rohan Pashetkar, Pratik Tambe, and Amay Purandare. They have kept the cool, they have kept the efficiency, and they have kept the energy very high.
Yes.
So it is my sheer privilege that today I am introducing Amay Purandare. He is a consultant obstetrician and gynecologist at Purandare Hospital, KJ Somaya Medical College and Super Specialty Hospital, HN Reliance Hospital, Manisa Hospital, and Mumbai Police Hospital. He is a joint secretary. He has been the joint secretary of Foxy last year, that is 2019. He has been the chairperson of Food, Drugs, Medical Surgical Equipment Committee 2015 to 2017. That's what Dr. Vidya Tobi was telling just before her, I think. And he's the assistant administrator of Foxy Manyata project on quality care in safe childbirth, member managing committee and member youth council MOGS, honorary secretary of AMOX 2014-15, zonal coordinator 2015-19, and state coordinator 2022. I'm sure we are going to be benefited by his talk because the cervical encerclage has somehow gone into a big controversy. Whether to do it or not, when should we do it, what are the actual indications. So over to you, Ameya. I'm really eagerly waiting to listen to. Unmute yourself.
Share the screen.
Thank you so much, Murlidhar Pai sir, for those kind words. They mean a lot when they come from you. I would
I
like
mean
to
every
thank,
single word.
yeah,
Yes.
I would like to thank AMOG's President Dr. Nandita Palshetkar, all the office bearers, Dr. Pratik Tambe, Dr. Rohan Palshetkar for having uh, convinced me to speak on this controversial topic, which is very near and dear to my heart because during my when I was in utero, there was a big debate between Dr. Shirokar and my grandfather whether I had to be whether the stitch had to be put or not. And finally, my grandfather said no, it should not be put because the cervix is long enough. But in spite of all the controversy, I was born premature about 34, 35 weeks of pregnancy. So probably it's been something which is with me right from my young days. More importantly, I have been awarded the R.D. Pandit Best Thesis Award for my research on cervical encerclage during my postgraduate days by Foxy. So from that time, I have closely looked and have been passionate about this topic. And I thank uh, all the organizers. A special mention of Dr. Vidya Thobi. Thank you for always remembering me in the Food and Drug Committee. And in fact, when I was chairperson of the Food and Drug Committee, we did get the ISO certification for the cerclage needles, and now they are ISO certified. So let me move on to the talk without further delay. So, what is cervical incompetence? To put it simply, it is a condition in which the cervix fails to retain the conceptus during pregnancy. But in spite of such a simplistic definition, there have been arguments about the occurrence and the incidence of the incompetent cervix. Cervical incompetence is important in clinical practice because it has been recognized as a potential cause of preterm delivery and, more importantly, what we call as recurrent mid-trimester abortions, which were previously called as habitual abortions. The global prevalence of most published studies is that it affects only 1% of pregnant patients, but it is a cause of up to 20 to 25% of second trimester losses. The etiology is multivariate, ranging from idiopathic in most cases to congenital disorders, that is Mullerian tract abnormalities, septate uterus, bicoordinate uterus, DES exposure in utero, connective tissue disorders like Ehlers-Danlos syndrome, Marfan syndrome, etc., and surgical trauma to the cervix following conization resulting in substantial loss of the connective tissue, or even traumatic damage to the structural integrity of the cervix, as noted in repeated forced cervical dilatations associated with DNC. Remember, friends, that cervical competence is an active and not a passive phenomenon. It is a specific entity involving not just an abnormality or defect of cervical collagen, but is also due to either the absence of the usual cervical musculature in cases of congenital cervical incompetence or injury or damage of the cervical musculature caused by previous trauma. The function of the cervix during pregnancy depends upon the regulation of the connective tissue metabolism. Collagen is the principal component of the cervical matrix, and the others include proteoaminoglycans, elastin, and fibronectin. And biochemical changes are implicated in cervical ripening. These include a decrease in the total collagen, an increase in the collagen solubility, and also an increase in the collagenolytic enzymatic activity. Women with incompetent cervix therefore present with silent cervical dilatation, that is, they have minimal uterine contractions, and this is classically seen between 16 to 28 weeks of gestation. The patient presents with significant cervical dilatation of 2 cm or more and minimal symptoms. When the cervix reaches 4 cm or more, active uterine contractions or rupture of membranes may occur. It is a clinical diagnosis, therefore, marked by gradual painless cervical dilatation and effacement, with membranes at times visible through the cervix. Short labors with a delivery of an immature or a premature fetus or loss of pregnancy at progressively earlier gestational ages in successive pregnancies is characteristic of reduced cervical competence. So therefore, the diagnostic criteria depend upon factors on history, first of all, namely history of painless cervical dilatation with preterm delivery, history of forceful cervical dilatation and evacuation, obstetric trauma like cervical lacerations, prolonged second stage section, prior cervical surgery like cone or loop, DES exposure in utero, and cervical sonography showing a short cervix and cervical funneling. But friends, improvements in diagnostics are there, but still it is largely subjective and retrospective. If possible, therefore, an objective or a measurable diagnosis should be made before pregnancy or in the early stages, that is first or second, early second trimester, and these would provide an accurate incidence of cervical incompetence, allow treatment to be targeted appropriately, and provide the basis for definitive trials of treatment. In the past, the various other diagnostic methods have been the dilators or the balloons to determine cervical resistance, popularly called as the Hagar's dilator test, HAGs to measure the width of the cervical canal between pregnancies, but these are neither sensitive or specific. Digital examination of the cervix is highly subjective, and therefore ultrasound, which in the last few decades has provided reproducible methods of evaluating of the cervix, now represents the most appropriate, accurate, and simplistic method of evaluating cervical competence. So how do we monitor cervical length? The optimal technique is TVS. Transabdominal correlates well with TVS only if done post-void to avoid artificial lengthening. Ultrasound is significantly more reliable than digital examination in assessing cervical length, which was proven first in Goldsberg paper way back in 1997.
Hello.
TVS allows for accurate cervical measurements with an empty bladder and no distortion. Besides the length, you also look for funneling or breaking of the internal cervical os, at rest or particularly in response to the transabdominal pressure on the uterine fundus called as the fundal pressure stress, which is characteristic of cervical incompetence. If you look here, you will find the relationship between the cervix, the internal os and the external os. And what you are seeing here is funneling, and the distal cervical length is small. The proximal cervical length shows dilatation. And a simple rule is that if the distal cervical length is smaller than the proximal cervical length, that is the residual cervix is less than 50%, it means that we are in trouble and this patient is likely to go into preterm labor. To put it more scientifically, we have the popular IAMS criteria, where funneling is described between with the relationship of the internal os, external os, and the cervical canal, which is called as the TYVU appearance, or to put it simply, trust your vaginal ultrasound, a mnemonic for the students. Cervical length should be less than 2.5 centimeters, or the rule of 24, that is at 24 weeks, the cervix should be longer than 24 mm. Protrusion of the membranes and presence of fetal parts in the cervix or the vagina. Here you see the characteristic schematic appearance of the T, Y, V, and then U, showing a continuum or a progressive change in cervical effacement and dilatation. These are actual pictures. Here you see the T, then you have the Y, here you have the V, and here you have the U with the herniating membranes. What is the fundal pressure test? USG serial evaluation of every 2 weeks of the cervix for funneling and shortening in response to transfundal tests has been found to be useful in the evaluation of cervical incompetence, as published first in 1997. Here you can see this is an image without pressure, and the same cervix gives way when transfundal pressure has been given, indicating that when provoked, the cervix is going to give up. Let us now move on to treatment once we have understood diagnosis and evaluation. Remember friends, the simplest way to more effective surgery is to choose the right patient, and that is the key debate in cervical incompetence, or when to stitch and when not to. RCOG has very clearly said that we must offer cerclage in those patients where there is history of 3 or more second trimester abortions or preterm deliveries, or history of previous second trimester loss or preterm delivery plus an ultrasound showing less than 2.5 mm length and a radical trachelectomy. You must not consider in other indications like multiple pregnancy or a previous cervical tear if the length is adequate. Ultrasound criteria include history of 2 second trimester losses or preterm deliveries with short cervix, uterine anomalies with or without hysteroscopic correction, and incidental diagnosis of a short cervix with no previous loss. As I told you, no intervention is needed if it's just a mere multiple pregnancy or if there has been a cervical biopsy or cervical tear, if the length and the integrity of the cervix is well demonstrated on ultrasound. The key to treatment of cervical incompetence has been well established as surgical repair, and the approaches are mainly vaginal and rarely abdominal or laparoscopic. The other alternatives that have been considered have included bed rest, for which there is very little evidence, and the use of vaginal pessaries has been tried in a few small studies which have thought to elevate and close the cervix, but is practically and routinely not practiced. So like Dr. Shirodkar said, the surgical approach to cervical incompetence still remains the mainstay of treatment. He said this when he published his monogram a few decades back, and it still holds true even as I speak to you in 2020. Now, what had the 2 pioneers of cervical cerclage said when they started thinking about this condition? In the early 1950s, Dr. V. N. Shirodkar and Dr. MacDonald envisioned cerclage as an appropriate treatment, and I quote, for women who abort repeatedly between the 4th and 7th month, where one can, by repeated internal examinations, find that the cervix is gradually yielding, who present with dilatation of the cervix and bulging of the forewaters during the second trimester. What did these words tell us? These words told us when to look for it, that is between 4 to 7th month. How to look for it? Obviously, they did not have ultrasound, So they said you need to look at the cervical length and cervical change. But these words can be extrapolated into modern practice, is that we need to have a screening technique and we need to have ultrasound to reproduce these changes or to document these changes and then put in the stitch in those who satisfy the diagnostic criteria. The older terms were prophylactic cerclage, elective cerclage, therapeutic or salvage cerclage, rescue, emergency, or urgent cerclage. And these have changed now to newer nomenclature like history indicated cerclage, USG indicated cerclage, and physical exam indicated cerclage. Obviously, they have history tells you prophylaxis, ultrasound tells you therapy or salvage, and or an emergency or an urgent cerclage. The ACOG has simplified the indications into three. One, history compatible with an incompetent cervix and USG change, or clinical evidence of extensive trauma to the cervix. Contraindications to cerclage include uterine contractions. Remember, a woman in active preterm labor, you cannot put in the stitch, it may not help. Uterine bleeding, chorioamnionitis, premature rupture of membranes, severe maternal disease, and fetus who has an anomaly which is incompatible with life. The 5 different cervical cerclages are the McDonald procedure described in 1957, Shirotkar's procedure in 1955, worm stitch in 1961, transabdominal cerclage in 1965, and the lash procedure in 1950. Amongst all this, you will all agree that the most common performed are either the McDonald or the Shirodkar cerclages. Obviously, we have our own modifications of these, and these have evolved over the last 50 years. You will see the words low and high in this particular slide. Remember, low stands for one which is closer to the external os, and high stands for one which is away from the external os or closer to the internal os, thereby meaning that the McDonald cerclage is usually at the level of the external os, while the Shirodkar cerclage is closer to the internal os. It is as high as possible. Let's move on to the McDonald procedure. It is done with a 5 mm band of permanent suture which is placed high on the cervix and is indicated when there is significant effacement of the lower portion of the cervix. It is to be generally removed at 37 weeks unless there is a reason to remove it earlier, like infection, preterm labor, or PROM. Here you can see the classic purse string suture that is being taken. We start off at 12 o'clock position. With the help of this needle, we run through the cervical substance, and you can see that finally the knot is either tied anteriorly, some prefer to tie it posteriorly. I prefer to leave a loop of thread so that it can be easily caught at the time of removal. 4 or 5 bites are taken with the needle to create a purse string around the cervix. The advantage is that it's fast, it does not require bladder dissection, and therefore minimal chances or no chance practically of bladder trauma. Shirotkar's operation was devised as a permanent purse string suture that would remain intact for life. At present, we have modified it where the delivery does not necessarily have to be by cesarean, nor the suture has to be left intact. These are the Shirotkar's needles that I was talking about. The suture is placed as near the internal os as possible. Therefore, an incision has to be made on the anterior portio vaginalis and adjacent to the bladder is dissected up and away. The suture is placed submucosally and tied anteriorly and posteriorly, and the knot is buried by suturing the mucosal opening so that it doesn't irritate the vagina or the bladder. Here you can see the bladder is being dissected, pushed away, and the knot is being applied tied anteriorly. Some prefer to tie it posteriorly because they feel that it may irritate the bladder anteriorly. Is there a comparison between Shirotkar and McDonald? First, let me talk about the similarities. Both initially started suturing with catgut and they realized that they were failing because they needed a permanent tough structure to suture this incompetence. So Shirotkar turned to fascia lata and McDonald turned to silk as they realized the importance of a permanent cervical support. I wouldn't call it permanent. The correct word would be a strong or a non-absorbable cervical support. One significant difference since then has therefore been the present day use of the Mercilin tape, as I told you, which is a non-absorbable, very good suture material for this purpose. As far as trials are concerned, there has been no comparative trial, but individual trials have shown that they are equally effective to the extent of 70%. Users who have used both of these generally prefer that McDonald is easier to use, is easier to perform with no major difference in success. Moving on to the worms procedure. It is also called as Hefner's cerclage and is used in well-advanced cervical dilatation. It is usually done by taking a U or a mattress suture, so you go antero-posteriorly to close the cervix, and is of benefit when there is minimal amounts of cervix left. How effective is it? There are some small randomized trials which have looked at its efficacy. However, they have also shown that the rate of complications are much greater if you move from an elective procedure to an urgent procedure to an emergency procedure. Two main complications which have been looked for are rupture of membranes and chorioamnionitis, and you will see that they go on increasing as the cervical length shortens or the procedure becomes emergent. These trials have looked at the role of rescue cerclage at 20 to 24 weeks in symptomatic patients with bulging membranes, cervix about 4 centimeters or less dilated, no contractions. There is an evidence of reduction in neonatal morbidity and a delay in delivery by 4 weeks, but one must keep in mind that there are certain complications. I've already talked about the contraindications to cervical cerclage insertion, and this is the list on the other side. Let's move on to transabdominal cerclage. It was first described by Benson and Durfee way back in 1965. When is it to be used? After the failure of vaginal cerclage, which is generally used as the first line method in cervical incompetence. I'm sorry. So it is generally indicated in those where there is a failure of vaginal cerclage or in the presence of congenital abnormalities, namely in the past where those patients had DES exposure and the cervices were small or abnormal. This is the transabdominal cerclage, where you see that just like a section, you first cut the UV fold, expose the lower segment, identify the internal os, and then put in the tape, perform the cerclage, and then close the UV fold. Obviously, minimal handling of the uterus, and these patients will require compulsory cesarean section at the time of delivery. One most important point while doing this procedure is that the Marcelin tape which is there is to be passed through the broad ligament below the uterine vessels in the potential free space between the uterine vessels and the ureter. The suture is tied anteriorly or posteriorly, and this important space is very, very crucial because if you ligate the uterine vessels or the ureter, either it would cause abortion or it would cause urinary blockage, and that would be serious for the patient. Now, I talked about levels of cerclage, and I said that the vaginal procedures, you have a low level cerclage, you have a high transvaginal cerclage like the Shirodka cerclage, and the transabdominal cerclage. Does the level really make a difference? Higher the level, if there are failures in previous pregnancy, is one golden rule that you must remember. In other words, that the abdominal cerclage would be indicated if previously failed lower cerclages, and now the abdominal cerclage has been replaced even by laparoscopic cerclage. Moving on to the lash procedure. The lash procedure was first described to be performed in non-pregnant patients. In those patients who had had cervical trauma and which had produced an anterior anatomical defect. Here you can see this almond-shaped defect in the cervix, which has to be excised, and the cervix has to be reconstructed because this is the point of defect as described by Lash in his initial studies, and it was called as the Lash's isthmorrhaphy and has to be done via the vaginal route. Here you can see the fibrotic weak tissue has been excised, and then the cervix has been constructed by taking plication sutures. There is something called as an occlusion procedure described by Steer first, and it is basically a best of both worlds. In other words, you do a Shirodkar cerclage and an occlusion suture at the level of the external os. So the Shirodkar cerclage is shown in red at a higher level, and the occlusion suture is shown in blue at a lower level. It is generally done with Prolene. Here you can see this is the Prolene tape at the external os, and here is the Shirodkar's tape with the Mercilin tape at a higher level. What does this ensure? This ensures that the cervical plug which is present in the cervical canal, which is the gatekeeper for ascending infection, remains intact, and therefore the chance of infection ascending through this cervix and at this foreign body is minimized. In general, the complications of cervical cerclage include premature rupture of membranes, which is seen in about 1 to 9%, chorioamnionitis 1 to 7%. The risk increases as pregnancy progresses and as cervical change worsens, 30% for a cervix that is dilated more than 3 centimeters. Preterm labor, cervical laceration, or what we call as cut through, and this can occur at the time of doing the procedure or from scar tissue that forms on the cervix. Bladder injury, but it's rare, maternal hemorrhage, cervical dystocia, and uterine rupture. These two complications have been described on an occasion in patients who have gone into active labor, and therefore patients with cerclage should have the knot removed as early as possible when they go into labor. Otherwise, these problems could occur. In addition to cerclage, can we add on some other therapy which will increase the chance of prolonging pregnancy? Let me look at evidence and let me talk as what we do in clinical practice. Bed rest, evidence says there is no, guidelines say there is no evidence. But in clinical practice, we tell our patients to reduce activity, abstinence from coitus. Bed rest may not be feasible at all in all patients and at all times. Post-cerclage monitoring, guidelines tell us that you should do repeated ultrasound and fetal fibronectin, which is not found to be useful. And clinical practice, we don't do monitoring until the patient becomes symptomatic. Resuturing, no evidence and is rarely indicated. Tocolysis and antibiotics, though evidence tells us that they are not useful, we do use them, but only in the perioperative period, not generally beyond that. And progesterone, even though evidence tells us no role post-procedure, but we do use it on the basis of data. Let us look at the audit of cerclage, and it began with the RCOG trial in 1988. It made some very categoric statements. It said cervical incompetence is often overdiagnosed and as a cause of mid-trimester miscarriage. Therefore, cerclage should be only considered when history of miscarriage is preceded by SROM or painless cervical dilatation. Cervical cerclage causes only a very small decrease in preterm birth, but no significant improvement in fetal survival. And to put it statistically, this trial said 1 in 25 pregnancies actually benefit from cerclage. But the ACOG thought otherwise, and they said that cerclage is not indicated solely based on risk factors or prior cerclage placed for doubtful indications. And if we look at the latest trial published by Bergela in 2010, why I say that this is an important trial is because it was a meta-analysis of 4 randomized control trials involving 600 women. The population monitored was singleton pregnancy with a prior preterm birth, and they found that cerclage was effective at all lengths below 2.5 centimeters or 25 mm, and hence should be used. Should it be used in all patients? That is the eternal question. To be or not to be, as Shakespeare had said, but I as an obstetrician call it not NOT but KNOT, because the debate still continues. On one side, we all know a stitch in time saves 9. On the other side, we all took the Hippocrates' oath and we said, primum non cere, above all, do no harm. So as obstetricians, use the stitch appropriately. Just because you have a hammer in your hand, don't drive a nail into every wall, but use it judiciously. You may save one and all. Thank you.
Dr. Kiran, would you like to comment on it?
Yeah. Fantastic talk. Hello.
It's echoing, Kiran.
Yeah. Fantastic talk, Ameya. Before we go on to the talk, I bring greetings from my parent organization, that is AMOGS. And AMOGS, as we all know, was founded by late Dr. R.D. Pandit and Dr. C.B. Purandare sir. And AMOGS is a very strong, vibrant society of around 44 societies, and which is presided by Dr. Nandita Palshetkar and Dr. Arun Nayak as the secretary, myself as and Dr. Rajendra Singh Pardeshi as the vice presidents, Dr. Bipin Pandit and Dr. Sujata Dalvi as the other office bearers. I bring greetings from AMOGS. I also acknowledge the great efforts which have been put up by Dr. Padma Rao, Dr. Sulochana Gunashila in starting the Kasoga. And my hello to Dr. Shobhana Patel, the president of Kasoga, and greetings to my friend Dr. Kasturi, the secretary, and of course the other office bearers of Kasoga. Ameya, it was a fantastic talk, and as usual, you hit the bullseye every time you get on with the topic or with any other topic which is given to you. A very age-old topic, that is the cervical encourage, but you have described it very nicely. And of course, I think, would you like to comment anything upon the laparoscopic encerclage, Ameya? On the laparoscopic encerclage?
So I think it's a newer trend. We don't really have that much data as far as routine use. Skilled laparoscopic surgeons are using it. Whether it can be routinely used for every pregnancy to replace a vaginal cerclage, I'm still doubtful, and evidence is not yet shown it. I have seen it being used on one or two occasions, but I'm still not convinced whether we could have in those cases use vaginal as the first level. So I think laparoscopy would only be indicated to replace a trans-abdominal cerclage, but not a trans-cervical cerclage.
Okay. Fantastic. I also acknowledge the efforts which have been taken by Dr. Pratik Tambe, who is very much our Amoxian, and is taking great efforts. I think he has done the maximum number of webinars for Amox as well as his own committee. Thank you, Dr. Vidya. Vidya is like my family member for being associated with Amox. I also acknowledge the presence of Dr. Dhamankar and Dr. Basavaraj Sajan, the presidents of the Karnataka societies. So thank you so much. I also thank Bharat Serums, although the title is very catchy, Bridging Bharat. At least I don't know whether you have bridged Bharat, but at least you have bridged two states, Karnataka and Maharashtra. So thank you for the same. I guess, Pratik, we can have the next speaker if at all questions are there from the audience. I think Amir should be glad to take it. Anything?
Yes, sir. The Science Integra team has just informed me that so far there are no questions. I think everybody was spellbound with Amir's talk and forgot to enter questions into the chat box. So probably while the second talk is going on, those questions will come in, and we would request Amir to please be present for a little while so that we can address audience queries if there are any. For the audience, please enter your questions into the chat box, and we'll try and take as many as possible, and those questions which are relevant will definitely be taken in. Dr. Muralidhar Pai sir, any closing remarks from you before we go to the next speaker?
I would like to congratulate Amaya for very beautifully, lucidly telling every aspect of cervical encerclage. And as you correctly put it, it is not totally out of the armamentarium of a obstetrician. It should be judicially used, yes. And that beautiful point what you brought out, 24 weeks and 24 centimeter, 2.4 centimeters is a wonderful thing to remember. And that's all I would like to say.
Thank you, sir. We'd like to thank the chairpersons for doing the honors and for being present and logging in so well in time it's very difficult to see that kind of discipline in today's world. So I think, sir, you're a shining example to all of us younger generation. As I had announced earlier, unfortunately, Dr. Suchitra Pandit has taken ill, our past president of Foxy, who was supposed to be the first speaker. I managed to speak to her while Amay was speaking, and she conveys her apologies. We wish Madam well, and we hope she gets well soon. We'll definitely have her in one of the next programs that we have once she is better. Dr. Rohan Palchetkar, our first Joint Secretary of AMOX, who was supposed to be one of the chairpersons. Unfortunately, since Dr. Suchitra Pandit is unable to join us, Dr. Rohan has agreed to deliver a talk which is on a similar topic, which is pregnancy after 40 slash impaired ovarian reserve. And for his formal introduction, I would request the other chairpersons to please introduce sir. Dr. Satish Dhamankar, sir, you will need to unmute yourself, sir.
Good afternoon, everyone.
Good afternoon, sir.
Am I audible?
Yes, sir, loud and clear, sir. Please go ahead.
It's indeed a great initiative to bridge the gap between India, Karnataka and Maharashtra, and we are coming together for a feast of knowledge. And thanks to Pratik Tambe for taking the initiative and Amox and Kasoga together. I bring greetings from our society, Belgaum Obstetric and Gynec Society. And I have a privilege and honor of introducing Dr. Rohan Palchetkar, who is head of the unit of Bloom IVF DY Patil institution. He is the second joint secretary of AMOGS, joint treasurer of Maharashtra chapter of IIGE, managing committee member of Maharashtra chapter of ISAR, managing committee member of MOGS. At such a young age, he has achieved so much. And he has, on the way, he has got many awards like ISAR Yuva Orator for 2019, Foxy Yuva Orator 2020. He has been recipient of MOG's Best Youth Council Member Award in the year 2016 and 2019. At the same time, he has received a recipient of AOFOG Young Gynecologist Award 2019. And today, Dr. Rohan is going to fill the shoes of Dr. Suchitra Pandit. So you can understand the stature he has achieved at such a young age. He is ready to replace Dr. Suchitra Pandit today. And we are very eager to listen to you, Dr. Rohan.
Satish sir, thank you so much for the kind words. Talk about not putting pressure to fill in Suchitra ma'am's shoes. But I'm going to be talking about basically fertility after 40, which eventually, what do we say? It overlaps with the poor ovarian patient. So unfortunately, I am at my clinic and I don't have my laptop. So I'm going to request Pratik sir to share my slides, please. Yeah. So go to the next slide. Yeah. So basically, when we're talking about fertility after 40, we are considering women who are in the older age group. And as you've seen in IVF, we have been coming across cases where patients are coming to us late. And eventually what we have to look at is their ovarian reserve. So most of these patients end up becoming poor ovarian reserve patients. And eventually we think of donor oocytes as the priority because we want to ensure they get pregnant. We want to ensure that they have a good genetic outcome because the efficacy of Down syndrome and everything increases. But my entire talk is based on trying to ensure that their own genetic material is passed on to the offspring. So can I have the next slide, please? Yeah. So if you go to look at it, look at this graph. We all know about this graph, that your fertility keeps on decreasing as age increases. And you can see that there's a drastic decrease in the number of follicles after the age of 35. And you can see the increase in the proportion of the poor quality oocytes. So our job as infertility specialists, when we are looking at these patients, is to ensure good quality as well as I'm sorry. Yeah. So can we have the next slide, please? Yeah. So if you look at this decreased ovarian reserve, we know that there are finite number of eggs, and eventually there's a depletion of ovarian reserve with age, with poor quality oocytes. And aging oocyte is the major cause of infertility in patients above 40. So we know that so next slide, please. We know that there is a Poseidon criteria 1, criteria 2, criteria 3, and a criteria 4. And you can see that it's very clearly seen on the slides. The AFC and AMH are very sensitive markers, and they actually give you an insight on how you need to go forward. Next slide, please. So prevention, really, if you go to look at it, there's no evidence per se where you can actually prevent anything from happening, but the only modifiable thing I would say is maybe do an early age pregnancy, but that's again up to each person. If it's a personal choice due to social reasons, you have no right to force anyone to have an early pregnancy. Another option could be social egg freezing done at an early age. So even if you wish to conceive later after 40, you always have the option of using your own oocytes which have been frozen at an earlier time. Then you have ovarian tissue sparing surgery, prevention and early treatment of tuberculosis, and fertility preservation in patients undergoing ovarian tissue damaging therapies. Basically, patients who may have been undergoing chemo or radiotherapy for any cancers, or where they may require or some surgery where they need to remove the ovaries, ovarian tissue freezing can also be done now. So next slide. So now coming back to the fertility management. One, we obviously know that it's age-based, but now if you go to see this, to get at least one euploid embryo, you require, as you can see age-wise, once you cross the age of 42, you require more than 20 oocytes to get just one euploid embryo. And you can see what a challenge it becomes, because these patients don't really give us that many oocytes to begin with. So then the question of embryo pooling, the question of multiple IVF cycles ends up happening, and it does become a burden on the patients. So next slide, please. So generally, when you go to see, you require high dose of gonadotropins for these women, and all preparations are equally good. So protocols which can be implemented are the antagonist protocol, the mild stimulation protocol, the long agonist protocol, and you get the ultra short agonist protocol as well. I'm not going to get into too much details of this. So can we go into the next slide? So when you talk about GnRH agonists, we're talking about it's more effective than antagonists in young POR patients. So that's group 1. So it wouldn't fit into the elderly population per se, but there are recent studies which have been showing that there's no difference. They say that there is only a difference of 1 egg, but at the end of the day, what do we mean by just 1 egg? So for older patient, 1 egg could make a world of a difference. So it depends on what you have been using in practice and what you have been getting good results with. So what do? I generally follow the antagonist protocol or the mild stimulation protocol. And recently we have started using dual stimulation even in poor ovarian responders, where we end up doing 2 cycles in 1 month itself, so as to get a better oocyte yield, so that we don't have to end up spending more time on these patients to retrieve eggs. Another thing is embryo pooling. Basically what we do is we get embryos from each cycle till we collect a few and then end up pushing them. Another thing what we have seen is dual trigger. This dual trigger is basically giving your HCG as well as dual trigger. And so can we have the next slide? This dual trigger, basically this study was published just now in July 2020, where they used 384 cycles in Poseidon 4 patients. So basically those are your older patients with a poor ovarian reserve. They saw that out of these patients, the patients that received the dual trigger had more number of oocytes retrieved. M2 oocytes which were available were better. The fertilized oocytes were also better. The day 3 embryos and quality of embryos was much better in the dual trigger group. Therefore, we should actually consider using dual trigger in poor ovarian reserve patients, where we could possibly get a better result and give them a better success rate in IVF. So could I have the next slide, please? Another thing which was published in June 2020 was giving daily letrozole with gonadotropin. So you give letrozole throughout the entire stimulation, and it's shown to improve the ovarian response as well as the IVF outcomes in poor as well as suboptimal responders. So next slide. Obviously, adjuvants. We've been talking about adjuvants since forever. And I do believe that in poor ovarian responders, they do have a role to play. So can we go to the next slide? So you have multiple adjuvants, and I'm just going to be talking about a few of them in a little bit of detail. So we have the DHA administration. It generally started 3 months prior at a dose of 75 milligrams daily. There's a Cochrane review published in 2015, which included normal responders and 7 RCTs with poor responders. They said that it did improve the live birth rate with DHA pre-treatment. So next slide. Then there's testosterone gel, which has been recently introduced, where we apply transdermal application of about 10 to 12.5 milligrams. So the pre-treatment is basically you use it in the cycle prior to your stimulation cycle, say from day 2 to day 21, and then you stop it. So generally what I do is when I am doing pre-treatment, I generally put my patients on OC pills for 21 days. And during the 21-day period, I usually give the testosterone gel as well. Recently in 2019, there was a meta-analysis which included 7 trials. It suggested that the testosterone may increase the live birth rate, clinical pregnancy rate, increase the number of oocytes retrieved, and give us more number of embryos. However, all these trials have always been maybe of low power. So right now there's a T-transport trial which was aiming at providing robust evidence for the use of testosterone. So once this trial comes out, we'll actually get proper evidence to know whether we will have a result, whether testosterone is actually giving us a good result or no. Now, growth hormone is another drug which is being used quite frequently in poor responders. Generally, the dosage that is expected to be given is 4 to 12 international units starting from the second day of stimulation till the day of trigger. So what is the evidence that says we should be using growth hormone? So in 2018, there was 127 patients which said that there was no statistical significance in the ongoing pregnancy rate between the two groups. However, another study which was just published in Fertility Sterility in July 2020 said that they can improve reproductive outcomes in poor responders. However, there was no increase in live birth rate. So again, we're in a catch-22 situation, whether growth hormone is actually going to give us a good result or no. So again, that is something that we need to consider when using it. Next is melatonin, which is obviously available as 3 milligrams, or it's always available in a combination with some of the drugs. Oxidative stress in the peritoneal serum and follicular environment can result in poor oocyte quality. The mechanism of melatonin is unknown, but it's said to reduce the oxidative stress. Therefore, you have to understand that it is acting like an antioxidant, and therefore it can result in better oocyte quality. In fact, a study published in March 2020, which reviewed 10 RCTs, said that it significantly increased the clinical pregnancy rate, but not the live birth rate. It did increase the number of M2 oocytes and good quality embryos. I personally do use melatonin in my own practice, and I have seen good results. So I am a firm believer of using melatonin in my practice for this. Next is this ovarian rejuvenation. So our main problem is because of the decreased antral follicle count as well as anti-Mullerian hormone levels, we have to rejuvenate the ovaries to be able to give us oocytes. So you can see these various therapies that are available, and I'm going to be talking about them in detail. So let's first talk about intra-ovarian PRP. So could I have the next slide, please? So intra-ovarian PRP, 2018 was the first paper I think Scott Sills had published on intra-ovarian PRP, where he had used 4 patients who are in menopause. So he gave intra-ovarian PRP sonographically, and he was able to get 1 blastocyst from each of them. After that, there was a lot of questioning about how do we use this, what treatment do we use. Now, recently in June 2020, a paper was published which included 311 women in which intra-ovarian PRP was used. The success rate was 23% per transfer if you go to see. But you're talking about these women who possibly may not have had a pregnancy at all, because these were women with premature ovarian insufficiency. So they probably had a 0% chance. So to increase it from 0 to 23% actually shows a promising result with intra-ovarian PRP. And this can be possibly used with patients with older age group with a low AMH with a poor AFC. But they said that you have to say that it is an alternative experimental treatment option. So if you are considering using PRP in patients, you must think of, you must tell them that it is experimental treatment and it could or could not give us results, but it definitely showing some promise. And I'm sure in a few years, once we end up having more studies, it'll be more rampant in our practice. In our own team, we have already started injecting PRP transvaginally. Currently, we do have one patient pregnant and she should be delivering anytime soon. So hopefully you'll see a paper being published soon on that as well. Can we have the next slide, please? Stem cells, obviously bone marrow derived stem cells contain several types of stem cells, but the human bone marrow derived stem cells, they promote ovarian function by restoring either the estrous cyclicity, increasing the number of M2 oocytes and embryos. They promote the follicular growth, local vascularization, E2 secretion, as well as stromal proliferation. So next slide. So there have been multiple studies which have been done. So there was a study published in 2018 in Fertile Steril where they used 17 women with POR, and it was seen that in 81% of the patients where stem cells were injected, there was an increase in AMH and AFC within 2 weeks time itself. Then there's this other study which was in July 2020, which was an article in press which talked about human bone marrow derived stem cells which were injected in mice with chemotherapy-induced ovarian damage and into immunodeficient mice, which was xenografted with the human cortex from poor responders. So if you can see that stem cells is the next step in our management treatment. And with these animal trials going on, it's just time before we can use it in humans as well. And I'm sure in some time, donor eggs would probably be a thing of the past. Maybe not considering the next few treatments I'm about to talk about. Sir, can we go to the next slide? Obviously, IVF or ICSI, this slide basically says that you can either do IVF or ICSI in poor ovarian responders or in patients above 40 because the fertilization rates has seemed to be the same. So don't change your practice. Continue what you're doing because the results are equally good. So could I have the next slide? Then there's this ovarian in vitro activation. Ovarian in vitro activation, basically what they do is they do a laparoscopic ovarian harvesting and then they do cortical sectioning of the ovary. After this, it's exposed to a P10 inhibitor and a PIK3 enhancer, and it stimulates the AKT signaling and activates the dormant follicles. So basically, it can activate any residual follicles in some patients and allow them to conceive with their own genetic material. See, the entire point of this talk is to try and ensure that we are able to pass on the parents' genetic material to their offsprings. Could we have the next slide, sir, please? Then you have mitochondrial rejuvenation. So what they do is they take a biopsy from the ovary and then the precursor cells are cultured and frozen. Then the mitochondria are rejuvenated and then injected with the ICSI into the mother's egg. So this mitochondria basically rejuvenates the egg. You're getting more energy and you're improving the oocyte quality. So could I have the next slide, please? So this is what I spoke about when I said that whether donor eggs would be a thing of the past. So Johnny Zhang in 2016, what he did was he took the mother's oocyte, he took the donor's oocyte, and what he did was he removed the genetic, basically the spindle from the mother's oocyte and from the donor oocyte, and transferred the spindle from the mother's oocyte into the donor oocyte, ensuring a good quality oocyte and ensuring that the genetic material passed from the mother to the child. So this ensures the genetic material passes, but the oocyte quality is improved. So could I have the next slide, please? Then came pro-nuclear transfer. Nuno Costa Borges in 2019 went one step further. So what he did was he first created embryos, one with the donor oocyte and one with the biological parents. Once the pronucleus was formed, what he removed was the pronucleus where from the donor oocyte and basically the donor embryo, and he transferred the pronucleus from the biological parents' embryos into the donor embryo. So that again ensured a good quality embryo with the ability of the genetic material being passed on to the offspring. So these are some amazing treatment options which have been coming into fertility treatment, and you can see that they are actually going to change the future of treatment in infertility. So could I have the next slide, please? Obviously, technology. I am from the generation which believes in technology, technology, technology. And it's something what I've loved to learn from my seniors, because they truly believe that technology is the way forward. And it's, if not for them, we would not be learning. Like, I remember back in 94 when mom started her practice, she told me that success rates, OHSS used to be such an issue. They used to create their own culture media. But now with the kind of technology, for us, it's become so much easier, where we already have things in place and we are just looking to further it more. So this was something where oocyte meiotic spindle marker for blastocyst ploidy. Now, what the problem is, sometimes we are not able to create blastocysts and we may have to consider doing a day 3 transfer. Yes, the entire world is shifting to blastocyst transfer, but sometimes we may have that issue. So, and because sometimes we may want to consider doing pre-genetic testing, and then we may want to, so we may have to biopsy, but sometimes cost can be a factor, because as you know, at least in India, patients are paying for their own fertility treatment. So in those situations, there's something known as the oocyte meiotic spindle marker. So what this study, which was published in Jan 2020, did was they recognized the oocyte meiotic spindle. So obviously there's this technology called spindle check, through which you can see the spindle. So they divided into 5 groups. One was a normal spindle, B was dysmorphic, C was a translucent spindle, D was in telophase, and E, there was no visible spindle. So if you move to the next slide, you'll see that out of the studies that they did, they had 2,056 oocyte meiotic spindles classified, and they saw that there was a strong association between OMS, that's the oocyte meiotic spindle, and the blastocyst formation. They saw that with group A and group B, that's the normal and dysmorphic, there was top quality blastocysts seen in those, and euploid embryos were seen in dysmorphic as well as normal, while the others showed more of a aneuploid situation. So can we have the next slide? Next is obviously pre-genetic testing. So there was a study published in March 2017 where basically they were thinking of PGT for poor responders. They saw that in poor responders where PGT was done, the clinical pregnancy rate was 56.8%. And the miscarriages rates were 18%. So if you can see, the pregnancy rates in the POR group were very high, and PGT should actually be considered for improving pregnancy rates. Obviously, advancing age also requires PGTA, especially women above 40, because obviously we're worried about Down syndrome. So you want to ensure that you're transferring a euploid endometrium. There was a very beautiful line written on a PGTA that with PGTA coming into play, does age really become a factor anymore? Because if you're transferring in terms of obviously transferring a euploid embryo, because if you're able to get PGTA, the entire point of the genetic defects that can possibly occur are ruled out most of the times. Could we have the next slide, sir, please? So there's something known as NICS, which has come in after PGTA. So I'm sure all of us are doing NIPT right now at about between 12 to 16 weeks for our patients, where we end up taking the maternal blood. So NICS is something for PGTA, where it's been seen that the genetic material is thrown out in the culture media. So what we do using Malbac technology, we end up testing the genetic material in the culture media of the blastocyst, and you're able to tell whether they're euploid or no. So the biggest advantages of NICS are it's non-invasive, because you don't need to take a biopsy anymore. It's much easier because you don't need the technical know-how for a biopsy. There's no sample loss, again, because biopsy is avoided. You don't end up damaging the embryos, and you're safe. The sensitivity is very good. It is flexible because it's compatible with the NGS platforms, and the AI, basically the implantation potential instead of aneuploidy status, gives you a complete overall consideration. So could we have the next slide? So currently we have started doing NICS, and we have all patients ranging from 2 failures till 7 failures. We've had 15 pregnancies so far, and the miscarriage rate has been only 2 out of 15. So it is showing promising results, and most likely we are probably going to be shifting to NICS completely in the future. So could we have the next slide, please? So this is the end of my talk. Take home messages which you must see that adjuvants do play an important role do consider using them in your poor ovarian responders. Consider dual trigger prior to oocyte retrieval. IVF ICSI results are the same in older IVF patients. Offer everything available to the patient. It's their prerogative to choose whether they want to have it or not. Even if cost is a factor, it's their decision whether they want to go ahead for it or not. And obviously, the future looks very promising, where the need of a oocyte donor may be eliminated completely. Thank you so much.
Requesting the chairpersons to please give their comments, and then we'll move to the Q&A session. There are some good questions and answers, questions which have come in from the audience for both the speakers. We'll take those after comments from the chairpersons, please.
Yeah, congratulations, Rohan, for an excellent talk. The technological developments which have taken place in this field are worth awe-binding. But I would suggest that though we cannot force pregnancy on anybody or any couple to undergo pregnancy, the technology should not take over God's technology. The age is a big factor in pregnancy and its outcome. And many youngsters, young couples are visiting gynecologists nowadays and telling that we are not yet settled. So we would like to postpone the pregnancy till they become 30, 35. And we all know as the age advances, the chances of pregnancy decrease. But we also have to pursue them to complete their obstetric career by 30 or 35 in spite of different pressures they are facing. You have made it sound so simple, the technological advances which have taken place in this field. And I compliment you for such a wonderful talk. There will be a lot of questions, and I am sure you will be in a position to answer all of them. Thank you very much.
Thank you so much, sir.
Thank you, Dr. Satish Dhamankar. There are a couple of questions for Dr. Amey Purandare. The first is from Dr. Ranjana Jha, and her question is, she's from Bihar. Her question is, sir, in your opinion, which is preferred? Is it the Shirodkar circlage, despite its difficulty in execution, or the traditional McDonald, which sometimes we lazily do, but is less effective?
To put it simply, one is not better than the other. In those who are trained for Shirodkars, they should make an attempt to use the Shirodkars. In those who are not trained for Shirodkars, either they should get trained for it or use the McDonald's. The McDonald's is equally effective, especially in where the cervical the cervical incompetence is not of an advanced category.
Thank you, sir. And the second question is from another viewer. Here we don't have the viewer's name, but the question is quite pertinent, and it talks about that we have had recent RCOG guidelines about preterm labor, and these guidelines mention that you could offer either progesterone or a cervical circlage to women who are at high risk. This is an evidence-based recommendation from RCOG for the first time in 20 years. After the MAC trial, which you showed in 1997, for the first time in 20 years, the RCOG is saying that yes, cervical circlage definitely has a role to play. What is your take on this?
So, cervical circlage is indicated in those where there is a documented marked reduction in cervical length. In those where there is a minimal reduction in cervical length, progesterone could be used. But if there is a history of previous preterm birth or there is a history of cervical trauma, progesterone is not going to help in those circumstances solely. It's a surgically damaged cervix. It needs to be surgically strengthened. So that is the simple take on that. In a patient who is primigravida, where there is no previous history and there is only isolated cervical shortening, that may be the case where progesterone could be used and should be used. You need not put the stitch in those patients. Again, it will also depend upon the degree of cervical shortening and also any other coexisting factors which may be contributing or may contribute to the cervical shortening.
Thank you, sir. I think that is very aptly put. The next two, three questions are for Dr. Rohan Palshetkar, and the first of these is from somebody called Dr. Riddhi. Now, I know two Dr. Riddhis. I don't know which of this it is, or it's an entirely third
The
person. No
third
clue,
Riddhi, sir.
because that person has not given their point of origin. But the question is quite simple. What is the FSH range that you take for poor ovarian reserve?
So, sir, poor ovarian reserve, generally the FSH would be on the higher end. I personally believe that FSH and LH now should no longer be being used to assess the fertility potential of a woman. AMH is a much more sensitive marker, or you can even check the antral follicle count. But generally, if you're still looking at FSH, which I personally believe that you should switch over to AMH, is somewhere about above the range of 9 units or 10 units is when I do consider them to be poor responders. But personally, I always do an AMH. I'm not a firm believer of following FSH and LH for poor responders.
So I think if I can respond to that, most of the younger generation have grown up in an era where they only do AMH, and most of us old timers have now transitioned from doing FSH to AMH as a primary marker for the ovarian reserve. The next question is from Dr. Pallavi Agarwal, and she is asking DHA is to be given in which cases of POR? I think what she's trying to ask is which patients you would expect it to have maximal benefits where you would optimize and use DHA rather than something else.
So generally DHEA, again, when I'm using DHEA, I'm using it in a combination. I'm not using it isolated. Generally, I would avoid DHA if the patient may have a history of endometriosis. I do prefer not to use DHA in that. But generally, if I have an AMH which is low, even if it's a younger patient or whether it is an older patient, I'm quite comfortable with using DHEA when the AMH is sometimes below 1.5 itself. Because if you look at a fertility range of AMH, AMH is generally looking at 1.5 to say around 3.5 is the normal fertility range. But looking at the age wise, I usually take my cutoff for a low fertility as 1.8, not as 1.5. I prefer taking a slightly higher range because these are patients which generally require the treatment and would benefit from DHEA supplementation.
Thank you. And there are some similar questions from other viewers. One is from Dr. Ritu Nanda. Her question is: do you use any adjuvants to improve the outcome as far as oocyte quality and better live birth rate is concerned? I think you've answered that in the talk.
Yes, sir.
So that is already taken care of. Dr. Rita Billiangadi has joined in, and I remember doing events with her a few years back. I hope she's doing well. Her question is for you, Rohan, and her question is recombinant FSH plus recombinant LH, does it give better results as compared to HMG in older women?
So this is like opening Pandora's box, and this decision to use these drugs is going to be completely up to you. So far, whatever meta-analysis have come across, they have shown to be equally good with whatever drug you use, whether you're using even urinary LH, you're using highly purified, or you're using recombinant technology. So it's completely up to you. I personally look at using highly purified HMG for patients because they do have both the gonadotropins. Of course, if the patient is affording, you can definitely try it in the second cycle in case your first cycle may not have yielded good results. But generally, I think HMG is more than good enough to use in these patients.
So if I can respond to that, I was asked a similar question a few years ago when recombinant LH was being marketed by many of the multinational gonadotropin companies. And at that point, I had a very simple, straightforward answer that the extra one oocyte that you get, whether that is going to give you pregnancy or not, and whether the cost benefit analysis matters to you and your patient. That is a decision you will have to make on an individual case basis because
Absolutely.
there are no randomized control trials. It's not possible to do an RCT like this.
In fact, now there's a long-acting FSH which has also come into Europe. It's not yet come into India. So maybe with that we may see what other results we may have with that as well. So it is a long-drawn thing where we would have to take a decision after using it in our own practice as well.
So that concludes the question and answer session. I would like to invite Dr. Vidya Thobi and Dr. Basavraj Sajjan, if sir is tuned in, to please give us their remarks regarding this excellent scientific session that we've had so far.
I think where is I am not seeing but Dr. Basara Sajan. I tried to call him
He had
actually.
tuned in for a short while earlier. I had seen
Yeah,
him being live when Dr. Amay was speaking.
yeah,
I
yeah,
think
yeah,
he's tuned out now. He's
yeah.
locked out. Anyway, since
So
we have you as the office bearer of
yes, yes, yes. No, there are others also. Dr. Kasturi Dodimat is there, our Secretary General, who is one of the panelists for your session on recurrent pregnancy loss, and other speakers also. And Dr. Durga Das is our EC member, so they are also Kasoka family. So they are there with you for the panel, which will be the excellent panel for you, all Kasoga family. But I, as a treasurer Kasoga, I am very much thankful to Dr. Ameya Purandare and Dr. Rohan Palchetkar. He has 11th hour entry, but excellent entry.
Thank you,
So
ma'am.
it was very nice to listen to you after a long time. I think I listened to him in Hyderabad long ago, but it was an excellent talk, Dr. Rohan. I must congratulate you and Ameya as usual. So his talks are always inspiring, and he will quote all the updates also in his talk. And for my experience on cervical encerclage, that the suture material also matters. I used to do Shirodkar's very often, but once it was very difficult for dissection and teaching my postgraduates dissection, and there was a bladder injury also when one of my assistant professor he tried to do that. So after that we switched to McDonald's. Of course, I agree with Amey that whenever there is a very bad cervix or any previous history of tracheorrhaphy and all those things, definitely we need to have a abdominal procedure, and those really help. So thank you very much for contributing excellent academics, Dr. Rohan and Dr. Ameya. And
Thank
I think let us move on for our recurrent pregnancy loss, evergreen topic on webinars. And every time we listen to recurrent pregnancy loss, we are really lost, I must say. So every time new things we learn. So I think Dr. Pratik will take over to a different journey on recurrent pregnancy loss. I welcome Dr. Pratik Kambe to introduce all the panelists, and let us have the discussion. And
Thank
I
before
you.
think we
we
will.
move to the panel, I would just invite Dr. Murlidhar Pai and Dr. Kiran Kotapati, the other
Acha,
chairpersons, for
Kiran is
any
here,
closing
and
remarks.
Murlidhar, I don't know
So
Murlidhar is
whoever is
here.
here, because once we start the
Kiran
panel
is there,
next
yeah,
one
yeah.
Yes,
hour,
yes.
Kiran is always
I'm
busy. Again, he will switch on to some other
no,
surgery.
no, no, no.
So, yes,
Anyway, thanks a lot, Pratik. Rohan, it was a fantastic lecture,
fantastic talk. Yeah.
fantastic talk. I mean, always Rishikesh usually talks about all these all hi-fi things, but I guess you also have raised the bar so high. Pratik himself is sitting at the backdrop of a spaceship. So I think Rohan, your talk should have been more of Star Wars after 40 or something like
So,
that.
so it was the inspiration behind the talk.
Great. But thanks a lot, Rohan.
Thank
Very well talk. Thank you so much. Thank you, Pratik. I guess we should get on with the
yes, sir.
panel discussion.
Yes.
Yeah.
Thank you. Thank you, Vidya ma'am, Kiran, and Pratik for this opportunity, and to the audience for those lovely questions. Thank you.
So
Thank you,
can
Vidya
we
ma'am.
have the slides of introduction for the panelists, please?
Thank you, Pratik, sir.
Thank you very much, Rohan, for stepping in, and we really are indebted to you today for saving the day. It's my proud privilege to proceed with the panel, which is on recurrent pregnancy loss. And amongst us, we have a host of dignitaries from all over the country and, of course, from Karnataka. To start off, we have Dr. Durgdas Asaranna. He is a consultant at Kasturba Hospital in Tumkur. He's the president of the Tumkur OBGYN Society, and we are really privileged to have Sir with us today. His areas of special interest include high risk pregnancy and vaginal surgery. Sir is an associate professor at the Medical College in Tumkur. Welcome, sir. Next slide, please. Dr. Kasturi Donimath has logged in, I think, even before I logged in, and she has been patiently waiting throughout this past couple of hours. She's the Secretary General of Kasuga, and she's the head of department of the OBGYN department at KIMS in Hubli. And we welcome, madam. Thank you so much for joining us today. Next slide, please. Dr. Rajeshwari Patil is the director of Sunshine Hospital and she is a fetal medicine consultant. She is also part of a genetic clinic and counseling center in Belgaum. Welcome, ma'am. We will love to hear your thoughts regarding genetic and chromosomal issues as we face them in treating recurrent pregnancy loss. Dr. Jyotika Desai is from Bangalore and her slide is so busy. I don't know which lines to
Yeah, yeah. And she
which
is
lines
also
to read out and which to not. But she is a very distinguished and eminent OBGYN and from Bangalore, won several medals. She's the secretary of the Bangalore Society, and we hope that she'll be able to join us. We may not be able to have her presence today because of a medical emergency, I think. That's what we have been told. And can we move to the next slide, please? Dr. Priya Vora is from South Mumbai. She is a managing council member of the Mumbai Society, a mentor of the MOGS Youth Council, joint secretary of the Mumbai Menopause Society, and part of the youth wing of AMWI. She's contributed chapters in various journals and books, and she's also been the proud recipient of the MOGS Dr. Durusha Best Committee Award twice. Can we have the next slide, please? Dr. Tabassum Dalla is the secretary of the Raipur OBGYN Society. She has a diploma in minimal access surgery. She's an active member of FOXY, has served the Raipur Society at several posts, and she's presented papers and delivered lectures in various national and state level conferences, received various awards, and also received the Women Empowerment Award by Go India Foundation Nari Shakti Samman presented by Acharya Prada, actively working for the betterment of women in the underprivileged areas. Special interest is high risk pregnancy and achieving pregnancy in maximum cases without IVF. Thank you so much for joining us, ma'am, today. Next slide, please. Dr. Kanchan Prasad, I think her video is off. Backend team, I think you will have to. I think I can see her. Yes, her video is on now. She's an associate professor with a fellowship and a diploma in reproductive medicine. She's part of the Muradabad Society, if I'm not mistaken. She's won Best Paper Prize at the Foxy International Women's Health Summit in Gurugram. Also won a Best Poster Prize at the PCOS conference, and she is past joint secretary of the Haldwani Society. Sometimes I wonder which society she belongs to. Sometimes it's Haldwani, sometimes it's Muradabad, but we welcome her and we hope we will have an engaging and fruitful discussion. Can I start my slide share, please? So while we are waiting for the slides to go up, I would like to announce that we have nearly 550 viewers who have logged in today, and a round of applause to all the faculty and of course the audience as well. I'm going to skip this slide because it's, I think, superfluous after we have already announced all the chairpersons. Hopefully I can, yes, it works. So welcome to all our distinguished panelists for this panel on recurrent pregnancy loss. I think we have a host of dignitaries, both from senior, mid-level, and lower positions, who will present their own individual ways of tackling patients with different etiologies of having recurrent pregnancy loss. I like to start usually with a quotation, and today I'd like to quote the Irish poet Thomas More, who once said that usually the main problem with life's conundrums is that we don't bring to them enough imagination. When you're treating recurrent pregnancy loss and looking for a needle in a haystack, which may be the cause, we need to use some imagination and certain guidelines. The first of these is the ESHRE guideline, which was published in 2017 November and which has been updated in 2019. It's freely available on the internet. Many of the things that we talk about during the next 1 hour will be partly from this guideline and from the other ASRM guideline, which is much older from 2012. And this will hopefully be updated very soon. We were actually expecting it to be updated this year at the annual ESHRE or ASRM conference. And we will look forward to new protocols being introduced by these two organizations. So let's start very simply, and I like to keep my panels very practical and relevant without talking too much theory. It is more important for us to talk about what we do in day to day clinical practice, what is relevant to us and our patients in the area in which we practice. It's all very well to say that now we have genetic sequencing that's available. It's not applicable to 99.99% of us in clinical practice in India. That is a sad fact. So let's talk about what is practical, what is relevant, what is doable, and what is beyond us in our own individual practice. And the first question which I'd like to ask Dr. Durgadas sir, is this recurrent pregnancy loss topic actually relevant in our day-to-day practice? Do you think we see the same number of patients with recurrent pregnancy loss today as compared to maybe 20, 30 years ago? Is it more? Is it less? Is it of any relevance?
Thank you. At the outset, I want to thank Dr. Vidya, Dr. Pratik, and Serum Institute for giving this opportunity. Coming to the subject as such, this is the matter of relevance because recurrent pregnancy loss is one of the frustrating event for the doctor as well as to the patient. The incidence is around 2 to 5% in the population. Recurrent pregnancy loss is challenging, though there is advance in medicine so much. 50% of the cause is not identified. So it becomes a frustration for the treating doctor as well as to the patient.
In your experience, would you say that the incidence is more compared to 25, 30 years ago, perhaps when you started your practice, or
Yes.
is it less?
Yeah, the incidence is increasing. 15% of the married couple are facing this problem nowadays. It was not so much in the earlier period because of so many reasons. Because one is the age of the conceiving mother. In the earlier days, by 2025, they used to finish their families. Now, because of their career orientation, the age of conception has been increased more beyond 30, 35.
Thank you, sir.
So, yes.
We'll come to the individual causes in just a little while, but I thought it's always good to be in the right frame of mind and be aware that recurrent pregnancy loss has a huge diverse range of etiologies. The incidence is more or less the same as it was in the past 25, 30 years, despite a lot of advances in science. And still today, despite all these advances that we have in diagnosis and treatment, sometimes we are still totally puzzled as to what is the exact etiology, how can we treat these patients, and of course, to address the mental and psychological issues which they all suffer because of societal pressure and because of various other issues related to treatment. I want to ask Dr. Priya Vora, madam, what is the difference between recurrent pregnancy loss and recurrent miscarriage? Are they the same? Are they different? Are we just splitting hairs? Can we use these terms interchangeably?
Uh, yeah, according by definition, according to the ASRM or the RCOG, there are different criteria. When you say RPL, RCOG defines it as more than 3 or more consecutive losses before the period of viability, that is less than 24 weeks of gestation. And according to the ASRM, it is 2 or more losses also that is considered as the recurrent pregnancy loss before the period of viability. And I think recurrent miscarriage should be confined to the recurrent pregnancy losses which have been means there is evidence that it was an intrauterine by the ultrasound and by histology by definition. So you
Thank you.
need to use, yeah.
Thank you, ma'am. So, though all of us in clinical practice use recurrent pregnancy loss, repeated miscarriage, recurrent miscarriage as interchangeable terminologies, when you are trying to look at scientific evidence and papers and analyze which treatment works best, it's necessary to have a uniform definition which is applicable in all studies. If your definition is not uniform, you cannot compare two different studies. You have to compare apples with apples. You can't compare apples and oranges. And that's why we are splitting hairs while starting this discussion. And we are trying to make you a little comfortable by looking at what are the definitions that we have. Now, this is the first case, and I'd like to always talk about different etiologies as a case based discussion. Now, the questions have been shared with all the panelists, so I'm not going to sit and read out every case, but I'll just briefly summarize and give you the relevant important points. This is a 30-year-old lady. She's married since 4 years. She's used contraception for the first 2 years after marriage, which is quite common these days. She conceived spontaneously a year ago, had bleeding in the second month, could not have any treatment. She aborted on her own. Second pregnancy was 3 months ago. She sought treatment. Ultrasound showed fetal pole but no cardiac activity at 7 weeks. A repeat ultrasound did not show any cardiac activity. It was diagnosed as a missed miscarriage. She was offered either a surgical or a medical method of evacuation. She chose medical evacuation because that is much less invasive. Now she is come to Dr. Rajeshwari Patel for an opinion, and she has a long list of queries. And each of these queries will be in turn asked to different panelists. For the sake of convenience, I'm going to start with Dr. Rajeshwari Patel. And this patient is asking you in a very troubled state of mind, Madam, what is the cause of my repeated miscarriages?
Good afternoon, sir. So, patient here has come like she's already in the state of confusion that she has lost the second pregnancy. We need to talk to her, counsel her, pacify her that there could be some reasons which we have to check first, counsel her, and tell her that it is like occurs in most of the cases, like between 2 to 5%. There is range that they might have abortions. Don't worry because she's just 30 years old. It should be like it. Of course, the recurrent pregnancy loss increases with the age, but we cannot directly tell her you're 30 or 35 and you'll be having increasing number of recurrent abortions. First, convince her and inquire about her history, like whether it is a consanguineous marriage or the first pregnancy, which she tells that it was diagnosed, means like she aborted, she's telling, but she has not undergone sonography, whether it was confirmed with at least the urine pregnancy test, because sometimes they have postponement of the menses and they consider it to be a pregnancy. And at least second pregnancy is at least it is diagnosed with ultrasound. So we need to think over here that is it is a second one she has lost, and we should ask her whether she has any investigations, because she's telling now this time it is second one. So she'll have gone to some other doctor, any investigations done, her thyroid profiles, everything is normal. If everything is fine, then we can ask her, fine, these are the things, not to worry, we can investigate you and find out like what could be the causes and reasons so that we can help you up in the next pregnancy.
Thank you, ma'am. I think you've made a lot of important points there. The first and most important, I think, for all of us is that there is no substitute for good history taking. Spend 15-20 minutes, get the entire history, the number of miscarriages, whether it was a proven pregnancy, and as Dr. Pia rightly pointed out earlier, whether they were demonstrable intrauterine pregnancies or, as you said, it was just a delayed menses. I'm going to ask Dr. Tabassum, madam, the next question, that the patient feels that maybe I got married late and I postponed having a baby for another 2 years by using contraception. Doctor, am I having miscarriages because I waited too long to have a baby? Is it because of my age, which is an issue?
So I would tell her that because she is 30, this patient concerned is 30. So 30 is not a very advanced age. I will not tell her that 30 at this point of time could be the cause of her miscarriage. But I would still explain her that she should not allow herself to postpone her pregnancies for a longer duration later on, so that she does not. I'll tell her that 20 to 30 is same, and 30 to 35 is almost same. So maybe age is not a reason of her abortions. Maybe she has got other reasons. So I would try to ask her I would try to explain her the other causes of miscarriages as well.
Yeah, so I think we have tackled this issue that often women tend to blame themselves. And of course, they are also helped in this particular endeavor by societal pressures, mother in law sitting on the head, and all sorts of counseling which happens from friends, relatives, neighbors, etc. All of us encounter this. The patient is in front of us for barely 5 minutes or 10 minutes, but they are constantly being surrounded by all these people who give their own advices, which may or may not be evidence based, based
Yes.
on personal experience.
So I would try to say that I will not discourage her by saying that 30 is very advanced age. Maybe she should have a positive feeling for herself.
Good. I'd like to request Dr. Kasturi to please come in into the discussion. Madam, we can't see
Yeah,
your video, but we hope you're there. In your experience, what is
sir,
the
you are able
age
to hear me.
cutoff? Yeah, we can hear you loud and clear.
But there
Only
is
the
a
video
problem
is
with the
not
camera.
working.
I don't know. I kept the video on, but it is not taking up.
No worries, ma'am. We can have your audio at least, and we would like you to respond to this query. What do you think should be the age cutoff if we can recommend that a patient should get pregnant? Ideally, I always like to feel that we as doctors should not be dictating when women choose to have a child or when they should choose to have the next pregnancy after the first child. But as a doctor speaking from a genetic abnormality point of view, do you think there should be an age cutoff which we can at least give
Yeah.
some pointers for the patient?
Yes, that is very relevant now. That's a more problem with the adolescents. Everybody is busy in their career. They are more career oriented than they give to the importance. So we tell the adolescents, even adolescents and the people, at least by 35 they should finish their family. At least one pregnancy, because after 35 the problems will increase. So we give a cutoff of 35, and it is really we need to educate the young generation about this age. They are
So, as
neglecting
you
it.
saw in the previous talk given very rightly by Dr. Rohan Palchetkar, that once you cross the age of around 35 in Indian women, the ovarian reserve declines quite sharply. The incidence of genetic anomalies and aneuploidies is higher. And we'll come to that in just a couple of slides. But the general pointer from the RCOG/NICE guideline, which you can see here, is that women should be sensitively informed. I like the way the British make things very politically correct. In inverted commas, they'll say sensitively, which means that we are advising them, but we are not making the choice for them. We are not directing them. You go and have a child just now, otherwise tomorrow you'll find it difficult. We be non-judgmental as far as possible and sensitively inform that the risk is lowest if their age is less than 35. I want to bring in Dr. Kanchan Prasad now into the discussion and ask her, for years together, we have always been taught that maternal age is an issue. We always tend to blame the female partner that, okay, the cause of genetic aneuploidies or abnormalities can be because of the female partner. Do you think there is any scope for blaming the male partner as well and saying that, yes, it could sometimes be because of paternal age also?
Yes, sir. It can be due to paternal age. Not only age, it can be due to paternal male partner lifestyle also. And paternal age, it is seen the DNA fragmentation more after 40 or more after 50. And especially the life, what is the lifestyle? Is he the BMI? More the weight, more the chances of DNA fragmentation testing, and other lifestyle, like if there is history of smoking or alcohol or any excess intake of caffeine, these can cause DNA fragmentation testing. In fact, if we see these factors in male, we can offer them testing for paternal DNA fragmentation.
Thank you, ma'am. I think this question is just to bring to light that we always treat all issues related to fertility and recurrent pregnancy loss as a couple's problem. It's not that the husband only comes once during the first consultation. After that, you will never see him again. Directly, he will come at the time of the delivery of the baby. No, the male partner is also supposed to be an equal partner. We counsel both of them as a couple, and we involve both of them at every stage in the investigation process, as you have rightly pointed out. Because of lifestyle issues, smoking, pollution all around us, DNA fragmentation can be an issue in the male partner even at a younger age, and these abnormalities can be passed into the conceptus, resulting in genetic anomalies and recurrent miscarriage. So though 20, 30 years back we felt that paternal age is not such a severe issue, today we have realized that it can be because of both partners. Of course, the male factor is something which we investigate only after we have exhausted all other avenues of inquiry. And DNA fragmentation test, I don't know how frequently it is done or how widely it is available in our country, but as fertility consultants, it's one of the important tests that we usually advocate, and it's something which all of us should be aware of. We should always try and keep this in the back of my mind. A very practical question that most patients have, and the very first question sometimes that they will ask you is, doctor, what is the chance of my having a healthy normal live baby? बच्चा होगा कि नहीं, इतना मुझे clearly बता दो. I am willing for all these tests and all these expenses that you are telling me. I will mobilize all that. We'll undergo all that. But do you think there is a practical chance that I will have a healthy baby? And in view of his experience over so many decades, I'm going to request Dr. Durga Das if he could kindly take that.
Coming to the age factor, just now what we have been discussing, the risk of miscarriage was around 20% at the age of 30 years. So once there is a recurrent pregnancy loss, what I do is I call the whole family for counseling. It's not only the husband and wife, even I involve the mother-in-law and the mother. Because once they go home, they sit on the head of the daughter-in-law, and the stress of the daughter-in-law will increase very much. There's a one part of the tender loving care we have to give, not only in our consultation chamber, even in their house. For that, I feel I should be the in-laws also should be involved. Number one. Number two, looking into the statistics, what I have seen at the age of 30, there was a pregnancy loss of 20%, recurrent pregnancy loss. Looking into the other side of the coin, the chance of healthy pregnancy will be 80%. What I mean to say is the same.
Focus on the positive.
Yes, the same thing will be conveyed to not only the couple but also to the whole family. What I make them is I make them sit and tell. We'll start investigating in all angles, and please don't lose hope even after 3 or 4 abortions, not only 2. Of course, nowadays losing 1 or 2 itself is a mental trauma to the couple and the family also. Coming to the case as such, the present case as such, we have seen 2 losses. One was in the 2nd month, second was in the 7th week, and 7th week was an embryonic fetus. Putting the criteria things together, it looks more like a genetic cause for this abortion, because the early pregnancy losses are more related to genetic causes rather than other causes. 50% of the early pregnancy loss before 8th or 9th week of gestation, 50% of them are because of the genetic cause. So I'll focus more on the genetic cause. Coming to the genetic cause, there will be 2 issues. One is genetic cause, genetic analysis of the parents. Second is genetic analysis of the fetus. In the olden days, genetic analysis of the fetus was not done because the analysis was done by karyotyping. To do karyotyping, we should have live tissues, number one. Number two, it should not be contaminated. Whereas product of conception, whatever we take and send to the laboratory, will be contaminated by the maternal tissues. So karyotyping could not be done. But present days, because of the newer techniques like micro CHG and all, product of conception analysis is easily done, and it should be done in every early pregnancy losses, because it gives lots of information to move ahead in the future management of future pregnancy.
Thank you, sir. I think we'll tackle the genetic issues a little, maybe 2-3 minutes later. Thank you for starting the discussion. I'll just like to point out that a very positive point that you have brought out, that even though the incidence of miscarriage may be 20%, there is an 80% chance that you can still have a live birth. So think about the positives, focus on the positive. And another very good point that you brought out is that maybe you need to focus on the in-laws and the family also while doing the counseling, and not treat it only as a couples therapy, but it has to be a family therapy. If you look at the evidence, this is an age-old paper from Human Reproduction published way back in 1997, which says that after 3 consecutive losses, the incidence of another miscarriage is as high as 29%. But after 6 losses, you can still have a 50% chance of live birth. And this is key if you want patients who are Google friendly, and for every small little thing, They have these devices called smartphones in which they will enter things and Google will throw up conflicting evidence with them. You have to be patient and guide them in an appropriate manner. There's a more recent paper, this is published in 2019, where they followed up 300 women over 6 years, and 80% of them conceived successfully, and 70% of them had a live birth. So, thank you, sir, for bringing out that point that though the numbers may seem high, because we always say that anything more than 5% is significant, still the incidence of having a good, live, healthy take home baby is quite significant and quite good. And that is what we need to focus on, especially when we are counseling the family. Dr. Tabasu, I'm going to bring you back into the discussion here and ask you, this is a patient asking you, do you think there is something wrong with my uterus or my cervix? Do I have some kind of infection? Is the infection that I have had in the past, maybe it was a candidiasis or whatever, which I treated, has it gone inside and damaged my uterus? Is it because of infection that I have recurrent losses?
I would like to tell her that infection itself cannot cause abortions. Chances of infection causing abortion is very less. Maybe it's just maybe 0.5 to 5%, I would say. So, telling about percentages, number one, I would say that this is the percentage. Then I would also like to tell her that these infections mostly are treated infections. So past infection cannot give infection at this point. I mean, abortions at this point of time. Maybe infections can give rise to infertility, but these kind of infections mostly will not give rise to abortions. But still, if she's very anxious, we would check for her infections and clear in her mind that these infections are maybe not there and she is completely fine. And we may treat her infection. If she's got a simple infection like a chlamydial, a candida infection, we can treat her and maybe psychologically she will be benefited with that.
Thank you, ma'am. So I think here it's important again to reassure the patient and tell her that past infections don't have a bearing on miscarriage per se, as long as that infection has been treated. Again, infections causing pregnancy loss are rare. They are usually responsible for sporadic miscarriages, and they are definitely not responsible for recurrent miscarriages. Though you can see there's a long laundry list of organisms which causes reproductive tract infections. Usually, the sequelae of these infections is either infertility because of blocked tubes or maybe a low grade endometritis, but it definitely doesn't lead to recurrent pregnancy loss. And there are various mechanisms postulated. We will not go into these because of paucity of time. And we'll move to the next part of the discussion, which is about toxoplasmosis and toxotiters. In just one sentence, if Dr. Kasturi, madam, you could tell us whether we should be doing toxotiters anymore in the 21st century.
No, toxoplasmosis, no, we don't do now. We don't even do torch test at all now. Only for recurrent pregnancy, we don't advise. We have taken it out. In the initial days when there was so much hi-fi, everybody, we also did for some cases. But then when it was proved that it is not a cause of recurrent abortions, we don't do it. It's not in our list of investigations.
Thank you, ma'am. So toxotiter and torch panel, I think, should be eradicated from our dictionary.
Yes.
The only place where you do torch titers if you suspect an acute infection during an ongoing pregnancy, where the patient has high-grade fever, has contact with the other carriers of that particular organism, which is called as Toxoplasma gondii. And for that, we have special tests called as avidity tests, which are now available, which will help you to diagnose whether there is an acute infection in pregnancy. Toxo as a cause of recurrent pregnancy loss is no longer considered in modern practice as a viable alternative. And now we'll come to the tests. What are the tests that you would normally recommend? And for this, I want to bring in Dr. Priya Vora. You practice in South Bombay. You have all the possible resources at your disposal. Within probably 5 minutes of distance from your clinic, there must be at least half a dozen NABL accredited laboratories which can give you every test under the sun. How do you use your clinical expertise and your judgment to decide which test to do and which to not do?
Pratik, yeah, the history also is important of the patient and even our examination findings once she comes to us. But at least the minimal tests which I would like to definitely do after recurrent losses are the blood sugars, a thyroid. The TSH is also very important, and ultrasonography also to see that is there any uterine pathology also. And if there is a indication of an infection, then definitely a high vaginal swab I would like to do also. And always, if the patient after 2 losses and all, sometimes they really want to know the cause and they are really insistent, then we would do a karyotyping of the abortus, and if required, then the parents.
Thank you. So, if you look at the evidence as it stands, there are very few tests which are evidence based and recommended today in modern practice. And this is from the ASRF guideline. You will find that they recommend that prolactin TSH as simple endocrinopathies should always be excluded. Do an HbA1c to see if the patient is a latent diabetic. Karyotyping, I think Dr. Durgadas has already broached the topic, and we'll come to that in just a couple of slides. Important to do the POCs for karyotyping wherever possible. If it's an interval patient who has come to you between pregnancies or after losses, obviously that's not an option. But parental karyotype you can do. There are certain tests you do for ruling out anatomical issues, which are listed here. And the last test, which we often do first before doing anything else, is the APLA panel. That is the first test that we tend to do, but that is usually last and much lower down on the list of investigations which are recommended. Dr. Durgadas, sir, you had started the discussion, and I'm sorry I interrupted you there. Could you further elaborate on what would be the possible genetic abnormalities which lead to recurrent first trimester losses? This is something which we have always been taught, but how has our understanding evolved over time, sir?
Yes. The genetic abnormalities, we are talking about parents and the fetus, product of conception. The genetic abnormalities may have two types. One is structural, another is number. The number of chromosomal abnormality is called aneuploidy, or structural abnormalities like translocation or inversions. Coming to the product of conception, what we are getting, we are sending it to the lab for genetic abnormality. The best part of this analysis of the product of conception are we can know a definite diagnosis and we can counsel the couple regarding that. If there is no genetic abnormality in the product of conception, straight away you can say the cause of RPL is not genetic abnormality. You can start investigating in other lines. If the product of conception shows genetic abnormality, then you see whether it's a structural abnormality or it's aneuploidy. If it is aneuploidy, you are very happy. You are going to have a very good prognosis in the future pregnancies. So nothing much should be needed except for parental karyotyping and further PGD. If the genetic POC shows any translocation and all, do the genetic abnormality of the parents. If the parents are also showing translocations, this is the real bad prognosis, because the future of the pregnancy with the parental translocation are very bad. What I mean to say, the RPL will keep on increasing with the translocations. So in such cases, your management is entirely different. You are going to have IVF, PED, or egg donation or sperm donation. The best part of genetic abnormality is, number one, you can authentically say this is the cause of abortion in your case. Number one, you can if it is an aneuploidy, you can console them. You can give assurance to them that in future pregnancy your RPL will not be. The chances of abortion will be reduced. As the number of abortion increases, the cause of genetic abnormalities will keep on reducing.
Thank you, sir. So I think you've brought out several important points there, and I'll list them out for the benefit of the audience. Number one is that ideally it is the abortus which has to be karyotyped. If that is not possible, then the parental karyotype should be done. often you will find that genetic abnormalities, which we've always been taught are responsible for first trimester losses, are sporadic in nature. They are not repetitive, which means that if you had an aneuploidy or you had a translocation in one pregnancy, it does not necessarily have to recur in a future pregnancy unless it is carried down from the parent, and therefore the parental karyotype also comes in into the picture. If you look at the ultrasound picture, if you have an anembryonic pregnancy, 90% of them are because of genetic issues. If it's the embryonic period, which is 6 to 8 weeks, then there is 50% chance. And if it is in the early fetal period beyond 8 weeks, then the incidence of genetic issues is much lower. Parental translocations, as we have seen, which may be balanced, reciprocal, or Robertsonian, are quite common, but they don't necessarily have to be transmitted to the offspring in every pregnancy. And you and I are not the experts in that. If you have access to a genetic counselor, then by all means, after the report has come, do refer them to a genetic counselor for a second opinion. Remember that all RPL treatment involves teamwork and a multidisciplinary team approach. What I want to ask Dr. Kanchan Prasad, madam, is, madam, in the area where you practice, if I'm not mistaken, that is Muradabad, which is a
Yes.
slightly tier 2 city. Do you have facilities for karyotyping and genetic counseling easily available?
No, sir, it's not easily available and it's not easily affordable by patients either. So, what I think, the parental karyotyping should be offered only if the RPOC, the POC shows unbalanced. If first we try to send the POC tissue, if possible, if it shows unbalanced translocation, or if patient has any history of previous congenital malformed baby, or if in family there is an history of any child who is having with unbalanced translocation, in that case only I would advise the parents to go for parental karyotyping. And otherwise, or especially if it is seen that if patient's age is less than 39, then the incidence is high. If that more than 39, then the chances of balanced translocation in female is less. So I think in that scenario only I will ask them to go for, because even they come positive, they will I will have to take into account all the aspect, even the because there is not much treatment that can I offer. I have to counsel them that even without treatment, the chances of live birth is good, not that bad.
Thank
Even
you,
they
ma'am.
come.
So I think that is very nicely illustrated that India is a land of great disparity and great diversity. On the one hand, you have the South Bombay consultant who is spoiled for choice as to how many laboratories she can send a sample to. And at the other end, we have people who are practicing in small towns and rural areas where these facilities are not available at all, and maybe the patient or the couple needs to go to a higher center for all these specialized tests. That being said, it's important to optimize whatever resources you have and do the best possible in the situation where you practice. I'm going to request Dr. Kasturi madam, with all her
Yes.
years of experience, just generally, what would be the treatment and guidance that you would offer this couple as a preconception counseling before they conceive for the next time? We'll come to individual causes in the subsequent cases, but what general advice would you like to offer, ma'am?
First of all, they are in, they feel psychologically upset, this couple. So we reassurance. We have to really counsel them. Counseling should be a real part of it and a good listening. So and we should counsel that we should instill confidence in them and positivity in them that they can have a term pregnancy, that it is not the end of it. So only thing what they need is they have to undergo proper investigations, diagnosis, and then proper preconceptional treatment. So preconceptionally, usually we put them routinely here. What we put is folic acid. We put them on methylcobalamin, and I put aspirin. This thing, somehow I'm getting good results, so I put it.
We'll come to aspirin in just 2 or 3 minutes, ma'am. But general advice regarding smoking,
So
obesity, weight control.
most of them are worried when should they go for the next pregnancy. That
Yes,
is the first
absolutely.
question they ask. So I tell them that as soon as they are psychologically prepared, they can go for the next pregnancy. It may be 2 months, 3 months, or 4 months. As soon as she and her husband and the family members are psychologically, one is that. Second is, after she has undergone all this investigation, we have may come to some conclusion what may be the probable cause. Then next will be whether after she has taken preconceptional treatment at least minimum 2 months. One and after 2 months, she has taken this preconceptional treatment, whatever we are going to put, and whatever lifestyle we have advised her, whatever some habits they'll be having that they have undergone. So all those has been corrected, they can go. But they need not wait for 6 months, 1 year, all that, as early as possible, the next pregnancy.
Thank you, ma'am. That I think is a very pertinent suggestion, that whenever she is mentally and psychologically prepared, and once you've ruled out all the diagnosable etiologies, then they can proceed. I want to ask Dr. Tabassum Dalla, madam, do you use progesterone in the subsequent pregnancy? Do you think it's useful? Is it evidence based, or are we just giving it empirically to all our patients left, right, and center because some pharma company comes and tell us, write progesterone for your patient?
According to me, I will not prefer to give progesterone until and unless I find a reason, like if she has a history of polycystic ovaries or irregular menses, then only I'll add a progesterone. It is not even evidence based. So giving progesterone to all recurrent pregnancy losses, complete no.
All right. So we have one school of thought that it is not necessary for every patient, even though the patient may have a recurrent pregnancy loss, that progesterone may not be of significant benefit. I want to invite opinions from the other people on the panel. Dr. Priya Vora, what would you do in your practice? If you don't start progesterone, I'm sure that somebody else practicing next to you, I'm not going to take any names and irritate anybody by taking their names, but somebody else will definitely start it, and then the patient will say, "पहले doctor ने तो बताया ही नहीं."
I think at least the tablets we can start. There's no harm in starting. Evidence is not against it, but then that's what, as you said, someone else will say that, oh, you already had so many miscarriages and how come the doctor has not put you on? So progesterone definitely has an immunomodulatory role. I think there's no harm in starting progesterone. The route you can decide. It really doesn't make any advantage of a particular route that you're going to be giving. And since there's no harm, I think progesterone and a folic acid, I think that I would start.
Okay, so Dr. Priya Vora wants to start.
And especially if there's an LPD documented, so definitely, like in PCOS and all these patients, anyways, we are going to be starting.
Let me ask the senior people on the panel, Dr. Durgadas sir, do you think that progesterone helps in patients of recurrent miscarriage? Is there any evidence which says that progesterone helps to prevent recurrent losses?
Yes, progesterone helps in the in RPL in two ways. One is with respect to LPD, and it supports the corpus luteum function. More beyond that, the present thinking is it acts as an immunomodulator, especially dihydroprogesterone will be a choice, 10 milligrams 2 times a day. That acts as an immunomodulator in carrying the pregnancy, because immunological cause is one of the upcoming cause for RPL. I do use especially dihydroprogesterone.
Okay, so there are differing points of view. I just quickly like to go through whatever supporting evidence we have. The Foxy GCPR says that progesterone is recommended for patients who have multiple miscarriages. You've seen in the preceding slides that there is an abortogenic shift where TH1 is more preponderant and causes impairment in continuation of pregnancy. We call this technically an abortogenic shift. There is also an increase in the cytotoxic antibodies, which are supposed to phagocytose the embryo, and the PIBF or progesterone modulated factor, which is responsible for immunomodulation, definitely does seem to play a role in a healthy and growing pregnancy. Administering progesterone, as Dr. Priya rightly pointed out, whether it's oral, vaginal, combination, all of the above, so on and so forth, definitely does have a role to play in continuation of pregnancy. Now, whether we choose one route over the other is left to the individual choice of the patient. In passing, I just want to mention Dr. Raj Raghupati, who is a person of Indian origin. He's done extensive studies in the use of progesterone to prevent miscarriage. You can look up these papers, and he has shown without any doubt that addition of progesterone definitely does benefit patients. In some cases, as Dr. Tabassum rightly pointed out, it may be empirical. But as Dr. Priya says, even if you don't write it, somebody else next to you will write it, and you will end up losing a patient. So the choice is left to the each individual practitioner, what they prefer and whether they would like to prescribe it or not, and which route of administration they choose. Let's go
So
to
can
the.
I add one this?
Yes, please. Yes, please.
Progesterone? So actually, yes, routinely we are using progesterone in different routes, and as you told, all the routes are good, and it acts as
All right. Thank you, ma'am. Let's go quickly to the individual cases now. The second
so only
case.
careful. Hello.
There are some audio issues, ma'am, from here. Please go ahead.
Okay. Only I'm careful in cases where I'm suspecting some genetic abnormalities. So when I'm really little doubtful about those cases, genetic abnormalities, I don't put them on progesterone because I'm afraid of continuing a very abnormal baby. So those cases I'm really careful. Other cases we do put.
All right, ma'am. Thank you so much for that input. This is a 28-year-old. She's married since 3 years. She's a village dweller. She's come to you for treatment, assuming that we are practicing in at least a city or a small town. She's conceived spontaneously immediately after marriage. Uneventful first trimester. Anomaly scan at 18 to 20 weeks was normal. She started having pain while traveling by train. Taken to the hospital, aborted at 5 months. Second pregnancy was 6 months ago. Similar history. She aborted at 4 months despite all the precautions that were taken. And I would like to ask Dr. Kanchan Prasad here, what would be your course of management? I'm going to cut to the chase. We all know that this is a classic history of a painless mid trimester abortion. For reasons of paucity of time, let us focus only on the management of this particular condition. What investigations would you do in the interval, and what treatment would you administer when she's pregnant?
I don't think it's painless. It is written it's pain by it was
Yeah,
with
the
pain.
first case was with a little bit of pain, but the second case, the second pregnancy, to be very specific, was a painless abortion. So let's
Oh.
focus on discussion of cervical incompetence. And though my good friend Dr. Amey has spoken about it at length, if you could just summarize few of the key take-home messages for us quickly, then we can move to the next case.
Okay, then it is a case of cervical incompetence, and where we diagnose it nowadays by ultrasound only. All those other things are gone, like with Hegas dilator, we used to do it, or with finger test, with digital examination. So now we do it, we diagnose it with ultrasound, where we can see either it is T or V or U. Or or it's then if it is not visible in normal case, we can put some fundal pressure, and under the influence of fundal pressure we can see the cervix changes its shape. So now sir already discussed is very good, Dr. Amya Purandare, when we do we what are the role of cervical encirclist. We can do either ultrasound indicated or history indicated or physical examination indicated, and there are three or four ways we can do, either McDonald's or Shirodkar or abdominal circulars. Obviously Shirodkar may have some theoretical advantage over McDonald's, but it is more a bit complicated, and not everyone is well versed with it.
So what do you
McDonald's,
prefer to do? Do you prefer McDonald's? Do you prefer Shirodkar, or do you want to do laparoscopic interval circulars?
I will do go for McDonald's.
Okay. So I think this is a topic which has been extensively covered, and we also wrote about this in one of our Foxy Current Updates newsletter last year when Dr. Nandita Palshetkar was the president. Topic has been adequately covered, so I'm going to move on to the next case. Yes, sir. Yes, sir.
Regarding cervical encirclage, I have one doubt.
Yes.
I think one is we have to put the stitch at least 15 days before the last abortion has occurred. Timing of this thing. Number one.
Classically, we like to schedule it at around 15 to 16 weeks after the first trimester scan has been done and the dual and quadruple marker tests have come back and they are reported as normal. So you know that without too much hesitation that even the 18 to 20 week anomaly scan is going to be 99% normal. Most of us in clinical practice would schedule it at around 15, 16 weeks latest, but not later than.
And another thing, assessment of the cervical length in the first trimester is not not indicated. So many times we have seen in the current report cervical length so much and so much. Usually we should start monitoring after 14 weeks, I believe.
So I think it is just mentioned there on paper for doctors who are practicing defensive medicine that at least if it is more than 2.5 centimeters, then you are on safe ground. If it was shorter than that in the first trimester itself, then probably you would be taken to task. I agree with you completely that only in the second trimester, when the fetal weight and the uterine volume are increasing and putting pressure on the internal os, that is when the serial monitoring should actually start, and it is of clinical relevance and significance. Good point, sir. So this is a 33-year-old lady. She is married since 5 years. Known case of PCOS and anovulatory infertility. Her weight is 100 kilos. She's tried to lose weight. Despite diet, exercise, and all things, she is not able to lose much weight. She conceived with IUI treatment 2 years ago. Had a first trimester loss at 6 weeks. Second pregnancy loss was also at 8 weeks. Dr. Priya Vora, this is obviously an endocrinological issue, and having done countless panels with me on endocrinological issues, I think you are the right person to answer this question.
After the two miscarriages, yeah, so this is a typical case where she has endocrinal issues. In PCOS, we do know that there is almost 3 times a higher risk of miscarriage because of the hyperandrogenism, the hyperinsulinemia, and even they have poorer pregnancy outcomes. So definitely now this patient was 100 kilos, what you have given. So definitely insulin sensitizers here would be really important. It would help her to reduce her weight in between the pregnancies. Even sometimes anti-obesity drugs like Orlistat, maybe you can recommend in between to lose a bit of weight. Now this patient is, I think, with a very high BMI. So I may consider the role of bariatric surgery also in her because, I mean, she's really, I think, 100 kilos according to your history. So if she fails to reduce weight with the other options, then definitely for better pregnancy outcomes, I would consider role of bariatric in this case.
We'll come back to bariatric surgery a little while later. I think Dr. Rajeshwari Patel had mentioned about starting aspirin. Madam, I'm going to bring you back into the discussion and tell us a little bit about how aspirin theory has evolved over the past 20-30 years. We used to prescribe 75 milligrams as low dose aspirin once upon a time. Do we still give 75 milligrams?
No, sir. Initially, we used to give low dose aspirin as before. Nowadays, with Advent, we are giving 150 milligrams because it mainly helps. Like 75 milligrams low dose, it is inadequate, especially in cases of APLA and where thrombophilic minor clots are getting formed. So where the minor clots may not be completely disintegrated with 75 milligrams. So they are adding now with quite many papers are presented with 150 milligrams. And especially even
so the dose is now 150 milligrams universally, both for treatment of patients with recurrent miscarriage as well as for prevention of preeclampsia or hypertensive disease of pregnancy, which is the more politically correct term to be used today. What I want to ask you, ma'am, is do you think that starting this at a particular time during pregnancy is of greatest importance rather than the dose? What do you feel?
Actually, in recurrent pregnancy loss, once the pregnancy is confirmed, we have to go ahead and start with aspirin, or especially if APLA is proved, like she's having anticoagulant history, then go ahead. And with previous history of PIH and then recurrent losses also, as soon as the pregnancy is confirmed, we can go ahead with 150 milligrams.
Thank you, ma'am. I'm going to ask Dr. Kasturi, with all her decades of experience, ma'am, do you feel that we should empirically prescribe aspirin to all patients of recurrent miscarriage for whatever little benefit it may give?
The evidence may not say, but I do prescribe.
Yes. This is the important distinction that I want to convey to the audience, that theory may say something, the guidelines may say something else, and in practice, unfortunately, we practice something which is not often evidence based, but we hope out of goodness, out of kindness in our heart, that it is going to benefit our patient in some unknown way, which is beyond the explanation of so called evidence based medicine. I'm sure Dr. Durgadas also will agree that we
Yes.
often give aspirin blindly to all our patients, especially if there is any high risk factor when this patient conceives or in the background in the past obstetric history. What I want to ask you, sir, is what is the right time to start it? Do you have any particular point when you start the aspirin?
Usually it is 2 or 3 months before. What I do is I start with 75 or 100 grams preconceptionally. Once we get heartbeat, I change out to 150 milligrams because for dilution of the thrombus, 75-100 milligrams are sufficient. But once the pregnancy has been set in, you are thinking of even preeclampsia, etc., and all one of the complications of uh, PCOS. The preeclampsia, one of the theories, inflammatory. 75 milligrams or 100 milligrams will not be sufficient for inflammatory process. So I will change over to 150 milligrams once the I diagnose pregnancy.
I think sir deserves a standing ovation in spite of being so senior. He has adopted all these modern practices, especially which we IVF people have been using empirically for the past 10 years. We have started at the point of preconception counseling, even while the patient was undergoing treatment so that she could conceive. We don't wait till the cardiac activity is seen on ultrasound to start aspirin. Maybe this is not evidence based, but this is something which we all do in clinical practice. I want to ask Dr. Priya Vora again about PCOS, miscarriage, and insulin sensitizers. If you could just tell us a couple of important points or take home messages. What is the appropriate insulin sensitizer? Do you think metformin is still useful, or would you use something else?
Metformin is a safe drug in pregnancy. It comes under the category B drug. So there are a lot of, at least in a PCOS, sensitizers have a role, and they can also be useful to prevent the gestational diabetes and improve the outcomes of the pregnancy and complications like PIH or the preterm births, which are much higher in a PCOS. So for this, definitely we can continue giving it beyond the first trimester. Again, we can, there are nowadays we have inositols also, but we do not, the experience we have or the data which we have with the metformin, because it was the first insulin sensitizer, we do not have much larger studies on the role of even myoinositols. And so it's again up to y'all, but I feel here metformin would be a good choice
Okay,
because we have enough data on it, on
let
safety.
me address this issue once and for all. Metformin is a good agent to use for PCOS patients who are trying to conceive. It helps in reducing the incidence of ovarian hyperstimulation syndrome. But whether it is helpful in reducing the risk of miscarriage is a big question mark. Initially, 20 years back, there were studies that showed lower miscarriage rates, but today the evidence is equivocal. We don't use it as an agent to reduce the incidence of miscarriage anymore. Having said that, if a PCOS patient is already on metformin before getting pregnant, we usually tell her, okay, you can continue it because it's relatively quite safe in pregnancy. I'm going to ask Dr. Kanchan Prasad, madam, do you have any experience with using steroids to improve your chances of continuation of pregnancy? Do we use it? I'm not talking about corticosteroids for fetal lung maturity. We are talking about steroids in the first trimester of pregnancy. Do you think it is safe? Should we use them?
No, sir, I do not use because it is not evidence based. Evidences say that it can increase the chances of gestational diabetes and other and hypertension. So I do not use it.
Dr. Tabassum Dalla, madam, any experience with using steroids for patients with recurrent miscarriage?
There were some data of using steroids for PCOS patients. So it can be used in cases with PCOS, but Cochrane, meta-analysis suggests that corticosteroids have no role in especially recurrent pregnancy losses.
Thank you,
So
ma'am.
discontinued using it.
So the evidence definitely says that meta-analysis does not support the usage of corticosteroids. But again, there are always some exceptions to the rule, and there are
Yeah.
studies specifically in recurrent implantation failure, which is a specific type of recurrent pregnancy loss, if I may put it, where it seems to give some benefit. Now, these are small studies with less than 100 patients. To what extent we can believe them, we don't really know. But you'll see that the implantation rate triples from 6% to 20%. Your live birth rates increase from 3% to 24%, and miscarriage rates, you can see the p value is definitely significant. So, as a last resort for a patient who has multiple miscarriages, you may consider this, though this is not evidence based. If the patient wants to try after counseling, she thinks that yes, like this particular study mentions, that there is 91% chance of miscarriage if you don't give steroids, and you have 70% chance of continuation of pregnancy. I don't know which patient will say, doctor, don't give it to me. All Indian
Congenital
patients will
anomalies.
say, doctor, please give me.
It
Sir, what
usually
about
helps when
congenital anomalies?
Exactly. So these are all the unanswered questions and the query issues which we cannot answer. Our science has not advanced to that
especially when
extent.
immunological factors are involved, it really helps a lot in such cases, especially
Correct.
in PCOS,
But we
plasminogen,
don't have
varicose.
large volume data which says clearly that yes, you should use it. These are small studies, and of course, we have to take this under advisement. I'm going to bring Dr. Priya Vora back into the discussion about bariatric surgery. Is there a specific cutoff over which you will say that yes, maybe this patient can benefit from bariatric surgery? If the patient is twice your weight or thrice your weight, is that your empirical criterion?
No, the BMI is important. If the BMI is more than 35, then definitely they are morbidly obese. And even the IVF results are not going to be successful. So there is enough evidence and data does show that IVF results also improve in patients who are after a bariatric surgery. Only thing, we need to wait for about 18 months before they again conceive, and the pregnancy may have nutritional inadequacies in that. So basically you need to give good supplementation and monitor the growth, and look into IUGR and during the course of the pregnancy.
I'm going to request Dr. Tabassum Dalla madam again to come in here and tell us, in Raipur, is bariatric surgery available, and what are the types of surgery that are commonly done in your area?
Yes, bariatric surgery is very well available in Raipur as well, and gastric banding surgeries they are doing mostly here, but it's not very popular still, and people still try to patients in that matter they don't easily agree to such kind of surgeries.
Very good. Thank you so much, ma'am. Dr. Kanchan Prasad, do you have any experience of treating patients who have already undergone bariatric surgery and now they are pregnant? Any tips that you can give us?
So they can, as Madam said, they can try after 18 months. Only thing that we need to monitor them more, because they are data has shown they are at increased risk of uh, preterm
Malabsorption
labor,
syndrome.
and yeah, they themselves have malabsorption syndrome, and so the fetus is going to be small for gestational age and preterm labor. So I do not have personal experience, but this is that I can say from data, because bariatric surgery I think is not that much common in India, and especially in tier 2 cities.
I think in South Bombay, 1 person in 3 has undergone bariatric surgery. Priya, would you agree? Everybody wants to be thin and famous and Instagram model style in South Bombay. So just quickly going back to the evidence, if you look at the HFEA guideline, it recommends 35 or 45 as a cutoff for offering bariatric surgery, because this is provided on the NHS. It's a free treatment. The patient doesn't have to pay for it. And the Indian guidelines suggest a cutoff of 50. It's not really something which is universally advocated. The most recent PCOS guideline also says that this should be considered as an experimental therapy. And after this long laundry list, which you can see of counseling that is recommended, then you can offer it to your patient. Let's quickly go to the next case. This is a 25-year-old. She's married since 3 years. She's had two losses. First was at 8 weeks, the second was at 10 weeks. She's gone to a doctor who's given her a huge list of investigations. Patient has sincerely done all the tests, and then after looking at her HSG and ultrasound, the doctor has advised her surgery. She's scared and she's come to Dr. Kasturi madam And she says,
Okay, sir.
"Doctor, this is the ultrasound report that the radiologist has given me. The doctor has told me there is something wrong on it and has advised me
Mm.
surgery. I am scared of surgery. Do you think this is required? Or do you think I can have a
Yeah,
normal pregnancy even without undergoing surgery?"
this looks like a septate uterus. The, yes, in septate uterus, if she has repeated abortions, if she has had repeated miscarriages with septate uterus, I would advise them surgery. It will actually, we have seen, I have seen cases where in septum, when they have repeated bad obstetric history, so they have improved after the surgery. They have conceived and then carried up to term. So we have a good number of cases where they have carried up to term. So I advise them if they have a septum.
Okay, so if there is a uterine anomaly, which is sometimes seen quite frequently in patients with recurrent miscarriage, what would be your choice of diagnosis, investigation? Would you prefer the age old HSG, or do you now think that we
Now
should
we can
resort
go
to
for
3D ultrasound?
transvaginal 3D ultrasound would be the best, non-invasive. Only in facilities where the people they don't have, they can go for HSG. Better than that is sonohysterogram by injecting saline into the uterus and doing a scan. That would give a better idea both about the anomalies, any endometrial polyp, submucous fibroid, any adhesions. All this could be could pick it up by a good ultrasound machine with saline infusion sonography.
So I think we now have
Sonography,
this
not TRICE.
modern classification which was given to us by Escher and ESG in 2013. We should be adopting this as a universal classification compared to the age-old AFS classification that we have all grown up. There is a standard form where you can document not only uterine anomalies but also cervical and vaginal anomalies. I think Dr. Durgadas sir has a point to make here. Sir, can you tell us how you would tackle this patient? How do
No,
you actually treat?
I want to say other things.
Yes, sir.
Whenever you see a uterine anomaly,
Yes,
just look into the renal anomaly also. Don't
absolutely, absolutely.
what I
Yes,
wanted
sir.
to.
You are absolutely right because renal anomalies and ureteric anomalies are
Yeah,
common.
you are going to manage the pregnancy and
Correct.
keep it in mind that the renal anomaly.
Absolutely right, sir. Dr. Tabassum Dalla, how would you treat this septate uterus? We are assuming for the sake of discussion that this is a long, complete septum without involvement of the cervix or the vagina. So this is a complete septum of the uterus. How would you treat this patient?
I would hysteroscopically remove the septum either by using a bipolar or a scissor.
Okay. And what are the tips and tricks that you can tell us? Where would you use scissors? Where would you use bipolar? Is there any cutoff where you would think that no, this patient will do better with a bipolar rather than with a simple scissors?
Most of the septum, they respond well with simple scissors because most of the septums are they are avascular. But if the septums are very thick, then we may use bipolar. Apart from that, we should be careful where we can undercut, but we should not overcut. We should always keep both the osteas in mind, and we should not go beyond the ostia so that we avoid any damage to the fundus of the uterus.
Absolutely right. So you can see that if you have a large, big, thick, fibrous septum, as you are seeing here, sometimes it is not necessary to only incise, but you may also require to excise. And doing that with a pair of scissors becomes long and tedious. And sometimes you will find that the bipolar resectoscope has come as a boon to all of us. You will find that usually these patients do well post surgically after you've given a post operative treatment with estrogen and progesterone cyclically for 3 cycles. Having said that, there are certain challenging situations like if you have a large and broad septum, you have a complete septum. If you have a boicolis, you're trying to inflate the uterus and distend the uterus from the other cervix, all the fluid leaks out. You can't achieve good distension unless you clamp the other cervix and close the cervical canal on that side. Of course, if you have other associated, as Dr. Durgadas sir rightly pointed out, if you have a vaginal septum or if you have a ureteric anomaly also, which is simultaneous, you would be very careful in trying to tackle this particular patient. I think we are running out of time, so I'm going to skip this particular case and go to the last case, which is quite relevant to our discussion. And this is the classic Apella syndrome. I'm not going to sit and read out everything on this slide because of paucity of time. I'm going to request Dr. Rajeshwari Madam to tell us how would you treat an Apella syndrome in the next pregnancy? How do you diagnose it and how do you treat it?
Yes. So mainly once we have to get her aplaprophidin. Nowadays added glycoprotein B is also added along with that in the routine panel. And in case she comes positive more than 30 milli international units or IgG, IgM come positive, then we come to a conclusion that she's having Apla syndrome, so that we can start treating her with one is low dose aspirin, we need to start her, and then the low molecular weight heparin is added for her. Usually, we give in our practice of 40 milligrams per day. We begin once she conceives, and it will be carried till 36 weeks. 36 to 37 weeks, we'll be giving low dose molecular heparin.
So I'm going to bring Dr. Kanchan Prasad here to add to what you've already said. Madam, can you tell us a little bit about what tests you do in your practice in the area where you practice? Are these tests freely available? What is the turnaround time? How many days do they require before they give you a report? And finally, are they reliable? You are muted, ma'am. You need to unmute yourself.
Apla test is readily available, sir. And yes, how actually Apla should be diagnosed when these either anticardiolipin antibody or lupus anticoagulant comes positive on two occasions, at least 12 weeks apart. Reason being because one time rise may be there because of inadequate sampling or because of even patient has infection. So that is why we diagnose it with two tests. And what madam said, yes, we treat it with ecospirin and low molecular weight heparin or unfractioned heparin, whatever is the choice. And we continue the heparin, I think, till the delivery, or if we plan cesarean, we stop it 24 hours before the cesarean, the heparin. And the ecospirin should be stopped at 34 to 36 weeks. And they should be started again after delivery. I mean, 6 hours after delivery and 12 hours after cesarean section.
Thank you, ma'am. I think that's quite elaborately and well covered by both of our panelists. I just want to make a point here that women who have APLA syndrome without a history of thrombotic events, you saw that there were various obstetric criteria, there were laboratory criteria, and there were thrombophilia criteria, which we had listed in the previous slides. Then you should give only prophylactic therapies like aspirin and heparin up to 6 to 8 weeks postpartum. Women who have thrombotic events in the past, like they have a DVT or they have a factor V Leiden mutation or a demonstrable thrombophilia, which is of course few patients in India, not so commonly encountered as compared to Western countries, you require full anticoagulation. Now, the vast majority of our patients are going to require only prophylaxis. So, this is only a theoretical concept, but it's important for us to realize that and know that. Coagulation cascade reproduced here for your reference. Can you tell us a little bit about the difference between the old unfractionated heparin and the modern low molecular weight heparin? Dr. Kasturi, madam, have you had experience of using this multi-dose vial of unfractionated heparin?
Yes, earlier we used to use that unfractionated heparin, that calculating the dose, and then most of the time we were worried, and monitoring them would be difficult. Every time
Because
doing
every time, every week or every twice a week, you would have to do PTA and PTTK, look at the INR,
maintain their
trouble the hematologist every time, and that person used to get irritated. ये twice a week मुझे phone क्यों आ रहा है? Patient बार बार मेरे पास क्यों आ रही है? So I think the low molecular weight heparins have revolutionized our treatment, made things much easier for us. You don't need to monitor, as Dr. Patel rightly pointed out, a simple dose of 40 milligram or 60 milligram per day, once a day, subcutaneously. Patient can subcutaneously administer on her own, and you don't require any special monitoring, less chances of antepartum or postpartum hemorrhage, and usually we don't need to monitor these patients. We've run out of time. We're at the end of our panel. There are several concepts that we could have discussed if we had more time, including the unexplained RPL, what are the recent advances in recurrent implantation failure, thin endometrium, immunotherapy, which is a very emerging frontier and something which all of us need to learn, revise, and I think unlearn and relearn. And some of the concepts about gene therapy, Rohan has already spoken about in his talk, but it's something which is more of a theoretical discussion, widely being available to us in Indian practice is going to take some time. I'd like to thank all my eminent panelists for a fantastic panel discussion, and I leave you with these immortal words from the two towers that there is some good in this world, it's worth fighting for. Appropriate, timely diagnosis, guidance, counseling, and tender loving care will go a huge way towards helping these patients who have recurrent pregnancy loss. I would like to invite some final closing remarks from all of our panelists before we call an end to the panel. We'll start with Dr. Kasturi, madam.
Yes, sir, excellent panel discussion. You have like brought every aspect, every minute aspect of this recurrent abortions into this, and nicely discussed. Actually, I am like amazed with the knowledge. You are an encyclopedia, and I'm sure all the delegates who are looking into it like really benefited. Those who have missed have really missed it. And one point is which I give very much importance is tender loving care and the support, and it really makes difference. I have seen some cases really that I call it spontaneous resolution, whatever, so spontaneous, even with or without treatment, with or just simple folic acid. If they have faith in us and if they get good tender loving care in their family support, some people have naturally conceived, gone up to term without much very high-fi treatment or anything. So it makes a difference, tender loving care and the confidence in the doctor, and doctors that instilling confidence into the couple. So that's we should not neglect.
Thank you, ma'am. Dr. Durgadas, sir, thank you so much, ma'am, for those kind comments. It's always wonderful to receive positive remarks from such eminent and senior personalities. Dr. Durgadas.
At the outset, I should thank you. The way you have conducted is really excellent. Thanks a lot, Dr. Pratik. And
thank you so much, sir, for gracing the occasion.
Yeah. And tender loving care is the ultimatum. Involve the family in this process, because she is already mentally traumatized. Let her get the boost from the family, and that's all I want to say. Thank you.
Thank you, sir. Thank you so much. Dr. Kanchan Prasad, your words of wisdom that you would like to convey to the audience. Please unmute yourself. You're still muted, ma'am.
Hello.
Yes, go ahead, please.
Yeah, I would like to thank you, sir, for this perfect panel discussion. You are master in moderating panel discussion, I must say. And for the audience, what I do, few tests which I must do at the first visit, advise them, that is thyroid, and try to do ultrasonography if possible, saline sonography, put some amount of fluid with the help of a IUI catheter which can be available at anywhere, and which gives you much idea about the internal, if any polyp or any some fibroid is there. So those correctable things you can diagnose at first visit only, and next test that can be advised later, second visit and second counseling, and of course the counseling of parents, especially a parent-in-law, mother-in-law, and the husband. That is also a lifestyle modification. And I would like to add some, nowadays they are adding vitamin D also, and I think we should add some vitamin D and some micronutrients also. And I give progesterone, maybe it empirical or whatever. So I give progesterone to the patient.
So we'll call you sometime when we are discussing thin endometrium and recurrent implantation failure and strategies to improve implantation, when you can talk about antioxidants in much greater detail. Thank you so much. Your points are well taken and much appreciated. Thank you so much for joining us. Dr. Priya Vora, any words of wisdom for you, for the audience, please?
Yeah, I would like to congratulate Pratik, excellently moderated. And definitely, as all the my co-panelists have already said, TLC is the most important, because patient is so mentally disturbed that psychologically you need to really put her in a positive mood and counsel and involve the whole family for this. And again, we need to restrict our investigations, minimize our investigations for early diagnosis, and treat the cause. And definitely there is a positive outcome. 80% of them do conceive and do take the pregnancy to term, as Saurabh also rightly said. Thanks.
Thank you, Dr. Priya. Dr. Rajeshwari Patil, ma'am, any tips and tricks for the audience, please?
Thank you. And this was a very good panel, sir. This is for the second time I'm participating with you. Here I would like to say, like, in mainly counseling is very important. Counseling the family, as sir said, and always include the husband, the male partner, because it so happens in our society only the female is brought forward and they say she has conceived, there is no problem with the husband. But whenever, most of the times when we are seeing the male partner, the semen analysis, we see the most of them are oligospermic and teratozospermic. So that also is one of the added factor for RPLs, which we need to consider so that we can counsel them and then go ahead with IUI or other things. Rest everything is covered by other sir and everybody. Thank you, sir.
Thank you, ma'am. And Dr. Tabassum Dalla, I think the last panel.
Thank you, sir, for a very smooth takeoff from your aircraft and a very, very smooth landing. And we enjoyed the journey to the maximum. It was a very nice panel discussion. One point I would like to bring about is nowadays we are seeing in this corona times sudden intrauterine fetal deaths. So maybe thrombosis may be a cause. So I think adding up ecosprin and heparin to even low risk patients at this time of time, at this particular corona times, can be done.
Thank you. I think this was very pertinent and relevant. Thank you, ma'am, for that point. There are some audience questions which have just been conveyed to me. So, with your permission, I'll just take them. We'll spend 5 minutes answering the questions. The first one is from Dr. Dwarkanath, and he's asking, is there any place of heparin for patients of RPL? I think we've tackled that just now in the last 5 minutes. Maybe the question came in earlier. There's another question from Dr. Rani, and her question is, what is the role and duration of immunoglobulins in RPL? That's one of the things which we didn't do. If anybody has any thoughts about that, you are most welcome to speak. The role of immunoglobulins or immunotherapy, as it were, is it offered where you practice? Do you think you have any practical experience regarding it? Not really. I think most of us don't really use immunotherapy.
We are not using it.
It is available in cities like Bombay, large metros, but then that's usually used as a last resort for many of our patients, and we don't usually use that as a primary alternative. Priya, you have rejoined us, I see. Any experience with immunotherapy where you practice? Not really, no. So I think this is something which is a very niche subject, and maybe we'll tackle it at some point of time in a future panel. Thank you very much for that question. There is a question from Dr. Datta who's asking, is the use of aspirin and LMWH recommended routinely in all high-risk pregnancies, irrespective of thrombophilia profile? And I think we addressed that as well by saying that there are things which are evidence-based, there are advices which come from international bodies, and then there is empirical therapy which we feel that may help our patients, as Dr. Tabassum rightly pointed out just now, just a couple of minutes back, that sometimes for the sake of being seen as doing something, we do in the hope that it will not harm and it will give some benefit to our patient. And the last question is from Dr. Smruti, who is asking, in the case of cervical incompetence for RPL, what is the ideal time for insert clutch? Is it interval or is it early pregnancy? We wish we could do it in the interval period, but often our patients only come to us when they're already pregnant and our hands are tied. I think Dr. Durgadas mentioned a little while ago that we do it around the 14, 15, 16 weeks of time as it's rightly prescribed in our textbooks. So thank you to all our panelists for a wonderful panel. For the formal vote of thanks, I would like to hand over to my co-convener, Dr. Vidya Thopi. Madam, are you around? Would you like to propose the formal vote of thanks, please, since you're here right till the end?
Yes, yes. No, in between I was not there, but I could.
But you have rejoined.
I have rejoined. And I must thank for an excellent panel. And I just wanted to introduce and reintroduce to our Karnataka Kasoga family, Dr. Pratik Tambe, because most of the Kasoga, because everybody was asking who is Dr. Pratik Tambe, then I told them that you will listen to him, you will really love him conducting the panel. Always, I think Dr. Durgadas will agree and Dr. Kasturi will also agree. See, he is showing his thumb. So most of our Karnataka state people, they have not
Yeah, you
listened.
told.
You might be. So it was a really excellent panel on recurrent pregnancy loss, and the talks from Dr. Rohan and Dr. Ameya Purandare were excellent. I thank Amox family as well as Kasoga family, those who have joined in, and those who were our participants. I don't know how many participants and viewers.
We have over 600 logged in, even now, more than
Yes.
600.
So I thank Dr. Nandita Palshetkar, Dr. Arun Nayak, and Dr. Kiran Kurtakoti, Dr. Pratik Tambe. These are the Amox family, and from Kasoga family, Dr. Kasturi Donimat, our president, Dr. Shobna Patel, and our EC member, Dr. Durga Das, and all the 4 societies, those who have joined their president and secretaries. And the panelists, I know very well Dr. Kanchan Prasad. Dr. Tabassum is my student actually. She's saying hi.
Very small world.
Yeah, there is no. I always often I meet her. I always go to her society, and we always meet in the conference. And Dr. Priya, I know very well, and Dr. Rajeshwari Patil. Namaskara, madam. So it was really nice to all of you have in this common platform. Hope we will meet again on this webinar with Dr. Again, one more webinar with Dr. Pratik Tambe. So thank you very much, Dr. Pratik. It is always excellent association with Dr. Pratik, always.
So thank you,
And
Dr. Vidya madam, for
yes.
being there with
Thank
us
you one and
in
all
this
those who have
journey.
joined. Yeah.
And at the end, I should also thank our academic partners, Bharat Serums and
Yes,
Vaccines,
yes,
and the
yes.
scientific backbone, Science Integra, Subbu, Seshan, Anuja, and Shrimon. Thank you for being here, supporting us in this scientific endeavor. Hope to see all of you very soon. Goodbye. Take care. God bless.
Yeah, thank you. The people are asking about the recordings. Maybe Science Integra people, they will
Yeah,
put it
we'll
in
share
the,
the recording with you in the group that is formed, and maybe you can forward it to the audience
to
as well.
all Kasoga family. Yes,
Sure.
yes.
Thank you so much, ma'am.
Thank you.
Thank you. Bye, everybody. Take care.
Bye, bye.
Stay safe.